Uterus. And in the first session, we'll be discussing about unveiling menstrual health equity, bridging gaps, breaking barriers to women's health. And to discuss about this very pertinent topic, I have a host of experts with me. Let me take this opportunity to introduce them. So we have with us Dr. Sapna Desai, who's a Senior Fellow, Population Council Institute, New Delhi, and Seva Health Cooperative, Ahmedabad. Welcome to the discussion, ma'am. Next, we have Dr. Sangmitra Pati. She's the Director, ICMR, RMRC, Bhubaneswar. Welcome to the show, ma'am. Next, we have Dr. Nirmal San, who's the Joint Director, Menstrual Hygiene Scheme, NHM, Ministry of Health, Family Welfare, Government of Tamil Nadu. Welcome to the show. Dr. Nirmal San, can I please request you to switch on the camera? Yeah, thank you. Thank you.
Yeah, all the best. Please go ahead.
Yeah, coming to you, Dr. Sapna. Am I audible now? Yeah, thank you. Coming to you, since you've been, working in the space of menstrual hygiene, when it comes to ensuring the health of, especially the reproductive health, menstrual hygiene and things like that. What have been your perspective? Like if we talk about the Indian scenario where there is a lot of, stigma and taboo related to reproductive health of women. So how would you define your experience if we come to the present status?
Thank you. And thank you so much for hosting this very important discussion.
Meanwhile, Dr. Amar has also joined us. He's the State Nodal Officer, Adolescent Health, NHM, Ministry of Health, Family Health and Family Welfare, Government of Kerala. Welcome to the discussion, sir. Thanks for joining us. Yeah. Coming to you, Dr. Sapna. Yeah.
Yes, so thank you so much for having me. It's a great opportunity to really discuss the core issues that I know we all care quite a bit about. So I'll share a bit of my perspective, and I come at this really from two ways. One is I've been researching hysterectomy for about 15 years, and so I almost came at it backwards, because seeing the prevalence of hysterectomy across the country and the variation across the states in the country has been an issue of great concern, where we've also had great progress. I mean, we now have national guidelines on preventing unnecessary hysterectomy issued by the ministry, for example, and a beginning to start looking at how we treat gynecologic morbidities in women. And to me, this signals the shift in our perspective away from only maternal and even around reproduction to thinking about women's health through the life course. So everything I say today, I really want to frame within that, which is that we need to consider women's health through the life course, not just adolescents who menstruate, women who have children, and then later women who we don't really think about much as they're continuing to menstruate and have gynec morbidities, etc. So just to start with that framing, let's think about women through their life course, starting with menstruation in adolescence, but really going through. So in my experience with SEVA, the Self-Employed Women's Association, where we've done a lot of programs and interventions around women's health for over 3 decades, one of the things we've really learned is, access to information. Women have access to information about their bodies and about gynecological health is very hard to come by. There's reams of information out there around nutrition, maternal health, family planning, but really thinking about women's gynecological health, the uterus, etc. There's been very limited information that's accessible and understandable. So that's been a really important aspect of the programs I've seen, working both with adolescents and importantly with adult women. What is, just to know your own body and to know the changes that the body goes through, and then to understand how to treat a lot of these issues. And that was at the core of preventing unnecessary procedures later, to know that there are many alternative treatments for things like heavy menstrual bleeding or the severe pain that many women experience later. So that's one in terms of information and access to information. And then the second issue that I'd like to highlight is access to alternatives. What we haven't really seen enough of are alternative interventions, alternative medicines, alternative sources of even information on what to do with issues around menstrual health and the burden of sort of morbidities related to menstruation as well as gynecological health. There's very little out there. Even if the treatments exist, we find at the state level and certainly going down to districts, these aren't well established, or you don't have feasible protocols for people to be using alternative treatment. So I think that would be the second really important priority in my experience. And then the third, as a researcher, I mean, one thing that has always struck me, and I continue to be completely struck by, we have such little data on the basic burden of what women are experiencing, again, from adolescence through, so past 44, past the reproductive age group, but also through menopause and post. What are the menstrual health issues women are dealing with? We just don't have basic prevalence data anymore. There were in some earlier rounds of national surveys. Not just prevalence, but also treatment options and what treatment pathways women are going down. We know so little. And, in my experience, that is the first step. It was the evidence on hysterectomy that really brought us to where we are today with action. And similarly, I think we need to take that broader focus back to women's health and understand the burden and understand what women's treatment options have been and what their life experiences are and the after effects of a lot of the things they're facing. I'll stop to hear from other speakers and then have to come back. Thank you.
Yeah, very rightly, ma'am. Thanks for that. Very rightly, you've pointed out how there is a lack of awareness. Knowledge is not there when we talk about alternate treatments, impact that those treatments can have, on their bodies. Coming to you, Dr. Sanghamitra, since you are from that, research area, because Dr. Sapna talked about how there is, unavailability of data also that somewhere down the line impacts the overall execution of programs. Coming from your background, what you think when we try to execute our research findings through, programs, initiatives. So there are certain, gaps that Dr. Sapna talked about in terms of execution and implementation. So what are some of the strategies that you have in your experience found to be really, really effective when it comes to, knowledge creation, executing that mindset, changing that mindset when it comes to women's health?
Okay, so first of all, I would take this opportunity to thank you, because when I was looking at the team, I feel it's a very equitable team. We have two men to support the cause of menstrual health, which is really heartening. I really like this team. And also it's a very, I would say, complementing combination of academic, policy, program, those who are actually the helm of the implementation or upon emulsion. So they are actually who see it in the reality or make it happen in the ground. It's the researchers who gives the evidence. But evidence to implementation is in their hands. So I'm happy that they are also here. And at the same time, I would take forward what very nicely Dr. Sapna Desai has articulated. First of all, I would just to touch upon in terms of equity, menstrual health equity, like what the research is and what the data points, and what has been our experience in terms of ensuring menstrual health equity, and what we found, for example, some evidence and which definitely requires further research. And I do agree with Dr. Sapna that we really need a nationwide, because there is inequity. For example, I mean, if you compare 3 decades back and now, definitely it has changed. I mean, when we were young girls, and now situation has changed. But there is still, in terms of disparity between urban, rural, urban, both. That inequity continues to remain. Because even if you look at NFHS data, or even if you look at any national representative survey data, we find that urban poor, or those who live in low-income informal settlements in urban area, face the greatest challenges in terms of managing their monthly menstrual health. In fact, the situation became more exaggerated during the COVID pandemic. All the house members, all the family members together were crowded in one house. I mean, you can well, and when the water, sanitation, everything was difficult because they couldn't go to a common place because of the isolation, because of the guidelines. So it's not that it was kind of, no one did anything, but it was something very unprecedented, which also gives us a thought or a food for thought. How do we make a menstrual health a resilient society, or how, so that even if there is any catastrophe, there is any disaster, there is any kind of untoward events, how do we make it happen for women as well? And secondly, I also feel that, in fact, now the government of India and all the state governments are taking cognizance of this fact that it's the life force approach which is very important, and that's why we have reproductive, maternal, child health, and adolescent. And that's why the government has encompassed the full life force. And at the same time, in the national NCD program, we are also looking at osteoporosis, which happens in midlife, post-midlife. And this connecting, I feel, the national NCD program, where we look at cancers, different or maybe different gynecological and reproductive cancers, and at the same time reproductive health, they need to speak together. There has to be dialogues between these two programs so that a woman is getting all the continued care during her life. In fact, for example, we were thinking today in our institute that why don't we screen for women when they come for their child's vaccination or infant's vaccination for postpartum depression? Because postpartum depression or antenatal depression are very common, but how do we detect them early when they come for their own infant's immunization? So that was some kind of, we have to find out some implementation modes, I would call them, or points of intervention where definitely the health system are going to take forward, because now the national NCD program also speaks a lot about intersectoral convergence, how the PRI department, WCD, school education, and health, they speak to each other for a comprehensive menstrual health program. And secondly, you might be, in terms of research, what we found is that alternate, I was speaking about the alternate. A couple of studies have been carried out, because what we find is that disposal of the sanitary napkin is becoming greater and greater challenge for women everywhere. And because of the waste, how do we really manage that? And we were examining the feasibility of a menstrual cup, whether it can be acceptable and feasible and culturally, because that is something very different from our culture. So is it culturally acceptable, or we go back to the cotton napkins that were previously used? So we have to give solutions, and based on their own context and based on their own, I would say, acceptability. So it has to be user-friendly and it has to be culturally sensitive. So all the solutions that we offer to these women. And secondly, we found that though there are, for example, I'm giving one example, though there are cups available, but the different sizes and this is not there. How do we customize this for the needs of these women? And secondly, now, in fact, we have prepared a draft menstrual health policy. Our state government is looking at it, and they are planning, which includes also leave for menstruation time, menstrual leave also, so that a woman gets a few kind of leave, so that when they want those kind of sorts of pain. And thirdly, I do agree, we really need to think how the women, because it's a monthly, it's not something every monthly ordeal, how do they have maybe psychological combined with some remedial, how do we develop a protocol for intervention so that they don't have to fear? And in fact, I will agree with the hysterectomy data. Many women do hysterectomy because they want to bypass or avoid this monthly event. I know, because I was a GP also in my initial days of my career. So many women go for that because they find it so painful that they feel that it's over. But while preserve the uterus is more important organ, because after that they develop hypertension, because we did a hysterectomy prevalence study and we found that around 10% hysterectomy is there, which is not a good thing to have, because your calcium is gone, osteoporosis sets in, hypertension sets in. So we really need to think together and identify few research priorities which can be taken as a task force mode, I would say, and multi-centric mode. Not what happens in Odisha may not be in Tamil Nadu. We will, of course, definitely get the opportunity to listen to both Tamil Nadu and Gujarat. So they would be having their state-specific best practices. So how do we create that kind of consortium, which not only does research, but also does a robust advocacy for taking that research into practice? Because unless it is being taken up into implementation, it only stays as a white paper, or it stays as terms of publication, which we do not actually want at this point of time. We want that translated for the benefit of the young women and all our young girls.
Right, Dr.
Remaining, I think, and I would really love to listen from here.
Yeah. So meanwhile, Dr. Neelam Divakar Gore, she's the Deputy Chairperson, Maharashtra Legislative Council. She has also joined us. Welcome to the discussion, ma'am. Coming to you, Dr. Amar, since you are in, when it comes to adolescent health, and like Dr. Sangamitra rightly pointed out that lack of menstrual hygiene is one of the main cause why women prefer going for a hysterectomy. So how would you describe the initiatives that have been taken in your state, especially when it comes to ensuring good adolescents' health, awareness around that? What have been your experience in that regard? You are on mute, sir. Yeah, you need to unmute. Yeah.
And now I think it's audible. So thank you very much for having me on board this very good discussion. It's very topical at this time. I work in the area of adolescent health, as I've been the state nodal officer for a long time now in Kerala. I think that when you talk of older women and the issue of maybe avoiding hysterectomies or avoiding the sequence of events that might lead to hysterectomy, we have to start young, catch them young, that kind of word. So we should start very early. And when we say start early, this depends on a life cycle approach. 4 words which I would like to put up here are: one is gender equality, the other is gender autonomy, third is women's rights, and the fourth is child rights. So these 4 words have to be there, not only as words, but in practice and as part of government initiatives, as part of the cultural framework. Part of this main, because we have had a very high literacy rate and what you call equality and gender autonomy, the freedom to what you call take up the reins of life in one's own hands. That is there to a great extent in the women of Kerala, and that is one very important thing. Women's rights and child rights are often overlooked by the public and the policymakers because we sometimes fall upon our old cultural roots and say that women are subservient to men and that women need to obey what men say. But we need to go by the 50-50 culture. It is not a time we should never try to take our culture back and say that women are less important than men. It's a platform where both are equal. So girls are equal to boys, women are equal to men that way. So this women's rights should be very much stressed upon. And child rights. Now children, we think that we can take all the decisions for them. But we should never underestimate our children. Today's children are very bright. Their source of information are many sources of information. So when we see that sometimes things are transacted at schools and other levels, but whether you do it or not, our children are going to get information. It is up to us to see that they get authentic, correct information rather than the distorted, pornographic or blue-tinted information that is so widely available on the net. So that means it means speaking up and making children aware of their rights, the autonomy of their bodies, the freedom to talk about their own body, and removal of sort of the element of shame on talking about certain things. Now, RSH always has been a gray area, so that shame should be removed. So this sort of advocacy should go to targets, such as children and women, to the caregivers who are even the medical fraternity needs to be sensitized. Because often a person who comes and demands or requests help or assistance in the area of RSH, people still are there who make fun of such people, such clients. So that has to go to medical and paramedical caregivers. The public at large needs to be sensitized to our mass media. And also one very important thing, men and boys need special dose of sensitization. Often they are outside the net. All our programs, there are so many women, so many girls sitting there, but the men and the boys are never seen. So it is up to them to make them aware that your sister, your elder sister, your younger sister, the girl across the road, the girl in your class, the woman working with you in office. So this sort of approach has to be there in the gender equality, number one. Number two, this I talked of this being a gray area. So removal of picking out research from the gray area compartment and making it very open. So we need to go by a very massive knowledge, attitude, and behavior chain or what you call sequence. Because knowledge is one thing, it's easy to give knowledge, but attitude building needs a lot of input. And that is where all our what you call literacy groups and local women sabhas and grassroots level, and there are so many bodies of women and girls. They need to be empowered and sensitized so that come out and talk. So talk, very important for building this knowledge and attitude. And once that attitude is built, then naturally practice becomes easier. So then we are going to see a sea change in the things that people do, the things that girls do, women do, to protect their bodies, to take care of their bodies, and what you call go for proactive care, not waiting till something is totally wrong and then going for care. Preventive and proactive care, very important. Number three, this is I'm talking about policy. So number three is about choice. Now, when we say choice of what you call information, where they should get information, choice should be open. And we should provide, system should provide so many choices. Materials and what you call commodities, there also choice is very essential. Now, Kerala, we see a huge movement towards menstrual cup. We were talking about menstrual cup in the initial previous speakers were talking about that. It's something that is being taken up by taking the women's segment by storm. There are so many girls and women who are what you call adopting menstrual cup in Kerala, and that has caused a revolution. All sections and strata of women are speaking up so vociferously about the change it has brought into their life, the freedom, this feeling of strength, the emancipation, the joy of being a woman. That is all now, because that joy was damped by the monthly period and the discomforts with that and the inconveniences. Now that has been removed. The joy is now coming into many women's lives, even at a very elderly age. Even people who are nearing the end of the reproductive life, even they are talking and with so many smiles, vibrant smiles we see all across because of menstrual cup. So that's the third area. Fourth is advocacy. I was talking about that earlier also, but advocacy in all varieties. We know that it's a vast spectrum. So that is fourth. Fifth is supplies. Now, when we talk of children, we know that what you call menstrual devices or menstrual management devices are very costly nowadays. They advertise and commercial brands come out at very high cost. We need to catch their neck somewhere and bring down the cost. It should be affordable to anyone and everyone. So the quality should be there at lower cost. And maybe for children in school and college, we even think of free supplies. But I wouldn't go for totally free, because what is totally free loses respect. So small cost, which makes it interesting, but at the same time, government bears the brunt of the cost. And finally,
thank you, Dr. Amar.
One little thing more in policy, we need to promote self-help groups and women's groups in the procurement side.
Yeah, that is very important. Thanks for those insights. Dr. Neelam, coming to you, are you able to hear us?
Yes, yes, I can hear you. Can you hear me, please?
Yeah. We would request you to please switch on the camera if it's possible.
Yes. Yeah, it's raining by, so slightly it's difficult, but we can talk. Yes, please ask me.
Right. So please, thanks for joining. Coming to you, Sir has rightly pointed out about how, affordability, accessibility is an issue, and how, if that is not maintained, the pure joy of being a woman is taken away. So discussing about on the same lines, when we talk about heavy menstrual bleeding, which is one of the leading cause when it comes to hysterectomies, so from your perspective, you think that lack of those basic amenities somewhere down the line, they become problems of such huge proportions that women opt to go, for hysterectomies. What are the reasons that, in your experience in the policy space, what are some of the reasons that, you think have driven women to opt for hysterectomies?
So, well, I think some of you must be aware that I was leading the committee for sugarcane cutter laborers in laborers from the sugarcane cutting community. They removed their uterus and many hysterectomies were done in B district. This report has finished now 3 years. It has been implemented by government of Maharashtra, I think I'm not sure, but this is one of the states who has put some, I would say, monitoring mechanisms in Bid and certain districts. Where if a woman below the age of 25, if she is doing hysterectomy, the doctors have to take permission from the civil surgeon. That is number one. Why? Because whether she is aware about the consequences of the hysterectomy and whether that is essential. Also, I will not take long time, but the obstetrician and gynecologists from the state, I would like to thank all of them for coming out with SOPs. Though there are SOPs existing for regarding hysterectomies, still they are not implemented, and sometimes it is done as per the wish or the demand of the woman survivors. That is number one. So this report needs to be discussed something more, and I'm trying to have more dialogue with the government all the time. There were discussions in the Legislative Council, and also there were discussions in the Bid district with the community workers. So when it comes to menstruation, still it is looked upon as a stigma in many sections of the society. Secondly, because girls are sometimes, either they are teased or they are commented about the menstrual bleeding. Sometimes they are not able to express something which is very natural. And so that becomes something like a stigma. That is number one. When it comes to married women, having more menstruation is definitely I would say, very big hurdle for them to work in the home or work outside the family. And thirdly, even in the professional field, it is very related to topic.
I think there's some issue with the connection, their internet connection, because your voice is breaking.
Some of the women, can you hear me? Hello?
Clear.
Hello? Yeah, can you hear me?
Now it's clear, Dr. Neelam. Yeah.
Now, okay. I will just take 2 minutes because I'm worried whether this connection will get lost totally.
Yeah.
But as a deputy chairperson of the Legislative Council, I will invite online or offline within council to have more discussion with the legislators.
I think there is some connection issue at Dr. Neelam's end. Dr. Neelam, can you hear us?
Health and reproductive rights in child department and I will just conclude with one sentence that let us work together more online and offline on these issues. And in Mumbai, to start the campaign from Maharashtra state, you are all welcome so that we can strengthen the ties in Maharashtra, and not only for the one state, but we can definitely strengthen it all over India. Thank you so much. Thanks for inviting me. Thank you,
Dr. Neelam.
Thank you. Bye. I will take a leave now. Good luck to you all and send me the details. Yeah, thank you.
So that was Dr. Neelam from Maharashtra Legislative Council. So Dr. Nirmal Sen, coming to you. Dr. Neelam, so Dr. Neelam also talked about how there is a sense of stigma and, taboo that is related when it comes to menstrual health. And especially reaching the more vulnerable communities is a problem. Awareness creation is important and it has to be culturally sensitive, as already pointed out by our experts. So what has been successful interventions by the, Tamil Nadu government when it comes to, ensuring and reaching remote communities, the most deprived and vulnerable communities, to ensure menstrual health, hygiene, adolescence, education?
Okay. So thanks for the opportunity and congratulations for the entire organizers of this program. So as rightly pointed out by the previous presenters, but I'm not going to those areas where they have touched. And Tamil Nadu, we are trying to reach the school students, adolescent girls who are studying in the schools and colleges. So we are covering almost 43 lakhs students who are studying, who are in the age group of 10 or 11 years to 19 years who have attained menarche. So all these kids are getting yearly 18 sanitary packs, which will be containing 72 sanitary pads. So we are providing 9 sanitary pads per cycle to all the school children and the college going children under the age group of 10 to 19. This is one of the promotion of sanitation, in personal hygiene and sanitation regarding this menstrual hygiene. So when we are ensuring that they are using this sanitary packs, definitely after their adulthood, definitely they will be using this in future. So this is one intervention what we have done. But Tamil Nadu being a pilot state, we have done from even now, we have done this from our state funds. We have started this program in 2011. So way ahead of Central Government of India doing this in other states. So we have done in starting from 2011, we are covering almost 40 to 43 lakhs. Initially, we have covered rural students. Then we have included the urban adolescent girls also. So right now, 43 students, we are ordering almost 8.3 crores of sanitary packs every year. The procuring agency is our Tamil Nadu Medical Services Corporation. It is, we are almost spending 12.5 rupees per 6 packs. This is the basic concept what we are looking at. The second one, the same adolescent packs. So the adolescent packs will be very colorful, and this will be containing 6 packs in this. And this is almost very hygienic, and it is tested. It is quality checked, and it will be given to the kids every second month. So all the odd months or even months, they will be getting this pack in the schools or colleges at their hand through the class teacher or nodal teacher. So second one, so we are ensuring that the schools are having a sanitary huda, so which is to burn the sanitary napkins. Then the second one, the sanitary napkins with wings. So this is also given to the mental health institute patients, inpatients. The third category, what the same pack has been given to all the inpatients aging from 15 to 55 years in all the government institutions, whether it is a government GH or medical college hospital and upgraded PHC. We will be giving that during the admission in the as an IP. When they are getting admitted, we are giving this. Another 2 criteria what Tamil Nadu government has done is to all the pregnant mothers who delivered in the government institution. We are giving a bigger size belt napkins, not this one, the another one with the belt napkin. We are providing to almost 5 lakhs pregnant women who are delivering in government primary health centers or in the government GH or in the government medical college hospitals. So again, for them, we are again giving almost 21 sanitary pads in 7 napkins, 3 sanitary packs. So this is covering the entire duration of their post 1 week up to the 1 week where they may be having the secretions from after the delivery. So this kind of things what we are looking at is to promote the sanitation and personal hygiene, menstrual hygiene from the age of adult or adolescent till the age group of that thing. So the stigma, definitely there is no stigma at all. Even in a co-ed schools, when the class teacher is giving this to the girls, definitely no one is objecting or doing any sort of unwanted comments to the kids. So all the things definitely will be in terms, because when we are catching them at the youngest age group, definitely the menstrual hygiene will be a good thing. As rightly pointed out by the previous speaker, that menstrual cup, right now the menstrual cup is definitely the problem with the sanitary napkins, maybe the disposal of sanitary napkins, which require again all the other issues. So we are also trying to avoid all these things. We are also trying this sanitary napkin. I think Kerala has done a very good thing in this menstrual cup, which has been sponsored or project done by the HLL, I think, in Kerala, and we are also roping that in, sir. So we are going to give initiate right now. We are going to initiate somewhere around 20,000 this thing on free of cost to the remote areas and 3 or 4 districts. Maybe in the next year we are thinking of giving this in the hilly region to all the menstruating females, because even though the hilly region, the reach is very tough. Even the medical shops are very lesser in number. The ordinary shops or ration shops or other shops are not having this menstrual, sanitary packs and other things. So we are trying to look at expand this to other areas, the menstrual cups also. So basically, right now we are catering 5 category of people: adolescent girls, inpatients in the medical in the government institutions, post-delivery mothers, then inpatients in the female prison. Missed out. So female prisoners in all the prisons, we are giving catering them also. We are giving them belt napkins, and the 5th one is the. We are covering 5 categories. So all these things are very good initiatives done by Tamil Nadu government. So any other things after the discussion will be joining.
Thank you, sir. Thank you. I'll come back to you. Coming to you, Dr. Sapna. Can you hear us? Yeah. So since your research has primarily been on how, hysterectomy and HMB being one of the leading cause, you think, somewhere down the line, when we talk about lack of awareness when it comes to menstrual health and hygiene, non-availability of, knowledge and things, in the longer run, they sometimes, make, like the expert said, take away the joy of being a woman. And especially when it comes to hysterectomy, because that was something you touched previously, but we were more, having an overview of menstrual health and hygiene in the country. Coming to the issue, which is, hysterectomies, the leading causes of hysterectomies, what has your research, pointed out at, when it comes to?
Sure. So I think we should see hysterectomy as a symptom of the issue, which is, as I think all of the speakers agree, is our lack of the options, starting with adolescence, whether it's a menstrual cup, and just, being able to manage menstruation in such a way that it's not seen as a burden, number one. And that's not only through interventions, it's also our own understanding and our norms around menstruation, which we do need to address head on. So I think if we look at it as a symptom, because hysterectomy isn't necessarily high across the country. So even in states where you don't see unindicated hysterectomy, we still need to talk about menstrual health and hygiene, as well as addressing burdens around gynec morbidity and what all the treatment options are. So starting with that, I think the research clearly indicates that this is a symptom of a lack of gynecological services at the primary healthcare level. Now, of course, we have states like Tamil Nadu and Kerala showing the way in terms of really starting to address these issues early. I really appreciated Dr. Amar's comment on, working with women's groups and self-help groups, to ensure that these are issues that are raised in different fora and not just through the health sector. Another piece of research that I find quite striking that I've looked at earlier was looking at just what adolescent boys and girls do seek in terms of treatment for symptoms of whether they're RTIs or STIs. So in terms of discharge, or, with women with menstrual related issues, or discharge in general for boys. And we find very different treatment patterns, even between girls and boys. So coming to the issue of equity and gender equity, are there options available that are feasible for girls to seek, and then moving on through adulthood for women to seek. So it's not just for heavy menstrual bleeding, which is one issue that, women self-reported in the NFHS. I don't think we really know the actual medical indications and the pathway that leads to whether it's hysterectomy or other treatment options. We actually don't really know. So I don't take that as the most serious it is obviously a serious issue, but I don't think that should be the primary issue we really hone in on is just heavy menstrual bleeding. We've got to think of this from, as you rightly pointed out, menstrual health and justice around the life course. So what my research says, to sum up, two things. One is that we need to think about gender equity and just availability of feasible options for different types of symptoms. And then secondly, ensure that we're thinking about this nationwide through primary healthcare. We have huge calls now for comprehensive primary healthcare. We have health and wellness centers. So this has been something, it's a huge opportunity through the health and wellness centers, through the NCD programs as well, is to really consider looking at gynecological health through the life cycle, starting with adolescence, moving to, postmenopausal life through our primary healthcare system. And I think that is really what the focus should be.
Right. You have very nicely summed up the whole, discussion that how the broader aspect of, life course, health, gender equity in healthcare needs to be looked at. Coming to you, Dr. Sanghamitra, when we talk about implementing, the observations as Dr. Sapna rightly pointed out, you think what role can, what collaborations are important, because like Dr. Amar also said that self-help groups, women's groups, they can play a very important role because it has to, everyone has to come together for that, for the cause actually. So you think what can be the best kind of collaborations that can help set the ball rolling when it comes to health equity?
Yeah, thank you. And I do agree with all my previous speakers that we really need advocacy, and advocacy which is multi-level. It's not only limited to only girls, and I would say it requires multi-faceted or multi-sectoral, as I was saying, convergence. But at the same time, I feel co-designing or co-production or working on the menstrual solution with the girls themselves, as very rightly pointed out by both Dr. Amar and Dr. Narshan, that the girls need which are friendly for their age group, and then let them suggest which is good for them. We do for contraceptives, like give a basket of options. Can you hear me now?
Yeah, now we can.
Okay. So basically, we need to give them choices, informed choices rather, so that they are able to make the decisions regarding their own menstrual health, which requires, I would suggest, is also some amount of activation, community activation. People need to be active and aware and consider it something as a part of their life, growing up, or which is going to be with them for long, not that something which is considered as hush or some kind of secrecy. I think, but people are coming out of it. It's not that everyone is still in that situation, but still I see some amount of social inequity. Not, I won't say it's purely gender, but it's also mixed inequity, wherein, for example, girls in metro and girls in urban slum, tier 2 or tier 3 town may not be having the same autonomy, the same level of menstrual health literacy. So how do we create a framework for menstrual health literacy and menstrual well? And here I would say that, again, do not look at only menstruation, also look at menopause. What traditionally happens that once a woman is out of the reproductive cycle, the program thinks she's out of the program, so she usually gets forgotten. So my suggestion or humble submission would be both menstruation to menopause. Perimenopausal problems, managing menopause is also equally challenging for a woman when she feels a bit depressed and feels left out and feels that she's no longer required by the system. So how do we create that inclusive approach wherein we bring in all the community partners, as told by both Dr. Merson and also Dr. Sapna, self-help groups, the Panchayati Das department, the PRI department, because they are concerned with drinking water and sanitation, and all of know the importance of access to water for menstrual hygiene. And most importantly, there are under the NHM, there are Mahila Arogya Samitis are there in almost all the urban areas. How can they can also be pitched in for creating a menstrual health awareness and menstrual health initiative? I would say we can give a very better, we can coin a term like menstrual health literacy, menstrual wellness, something like that, so that kind of a catchy campaign, and wherein people should have their ways of expressing their concern and ways of addressing them. I do agree. We really require some culturally sensitive, platform for girls to share, because they're growing up. Where do they share? With whom do they share? Is it ASA, or how do we prepare the community health workers to elicit such kind of information from the girls and also manage it? So that is very important, because they are going through a very, I would say, very difficult time, because growing up is a very difficult period. It's a transition period. And how do we really address those adolescent, parents have a lot of challenges in managing. So how do we really address all these concerns? It's very important. Whom do we prepare to address these challenges? And having health and wellness preparing, again, I would say women's health and wellness, not looking at women only for menstruation, only for menopause, or only for hysterectomy. How do we create that cycle so that the woman is taken care of from throughout her life period? That's what I would say. And also, we have policy people and we have program people. They will definitely have more concrete how to really do.
Thanks for those insights. Dr. Amar, coming to you, like Dr. Sangamitra pointed out about how we can have multilateral collaborations when we think of women health, ensuring health equity, life course approach. So what are some of the, initiatives that your government is hopeful of, implementing in future? What are some of the areas that you think need addressal when it comes to women health, and where you have been, working on? Let us know about. You need to unmute, sir. We are not able to hear you.
Yeah. Sorry. Convergence and collaborations are very important words in this area. So earlier I spoke of the theme that catch them young. So that means that right from the little school, or now girls are going into menarche at 10 years. So that means just barely out of primary and into secondary school or upper primary. So that means that education, Department of Health and Department of Family Welfare, Department of WCD, should be taking these things as part of their daily task. And that means that schools should not see that somebody, a doctor comes, a medical team comes and then talks to them. No, the school itself should be a health promoting school. And we assist them. That is the field that we are trying to encourage. The school itself is health promoting. And that should be supported by the local self-government, the Panchayati institutions, Panchayati Raj institutions, that they are the focal point. And they call the other departments for assistance. So the school fosters all these. Peer education, very, very important area. So trying to broad base and expand the peer education network, because children will talk among themselves. And informed peers are the most precious things we can have on board a school. Informed, open-minded, unbiased peer leaders. So they will spread good ideas. Our task is easy because we can disseminate to a smaller group and it will go to a huge area. Then also promoting the word counseling, because right now counseling means something that is done to a child. That's how the papers report in trouble, like sexual assault or drug case or something like that. No, counseling is something that every child has a right to talk and ask doubts. So counseling should be something very simple. The massive remarketing of the word is needed at this point of time. And there, the promotion of adolescent-friendly health centers and adolescent-friendly health centers, I would say, because the Government of India word is adolescent-friendly health clinic. Now, people go to a clinic only when they are sick. So we should be calling them adolescent-friendly health centers rather than clinics. And also school counseling centers. Those have to be promoted on a massive scale. And counselors have to be paid well, because counselors do a critical job. Unfortunately, across the country, counselors seem to be paid on a very low mode. So that's a very demotivating factor for them to do a good job. Then the creative use of a leverage of adolescent-friendly club meetings, which happen at sub-center level. Small girls and boys groups gather there, and adolescent health and wellness days. So here the focus is that infotainment. give the girls and boys a chance to get what you call showcase their ordinary creative talents, and then they will become open about health also, and then they will become open about reproductive and sexual health. So there, that is how the information, they ask questions, become friendly with the health people, and they clear their doubts. Can you hear me?
Dr. Amar, are you able?
I'm able to hear, yeah, but it broke. I think live connection. I can hear now, but hello. Hello.
We can hear you, Dr. Amar.
Okay. So the last thing in the area of promotion that we need is helplines. Now, Kerala state has a very vibrant helpline for health department called Disha 1056. So there you can call anonymously and ask anything and everything. And they link up to the adolescent counseling team. And so every child who calls gets a respectful treatment and respectful reception, and what you call very friendly buddy kind of information. So those are the things that will take this program of and having life skill approach at schools. Of course, our schools now through SCRT, we use a book called Ullasa Paravagal. It is a Malayalam word. Ullasam means enjoyment, and Paravagal means birds flying high. So birds flying high in enjoyment. That's the name of the book, Ullasa Paravagal. That is a life skill based book or syllabus book of for the schools. So for different classes, first standard, second standard, by third standard periods is starting for many girls. So right from third standard, things that girls and boys should know, and then it goes up in level up to 12th standard. So that way, I think a lot of openness and joy comes into it. So periods can be looked forward without fear, without dread, and as part of the what you call, we say abhimanam or respect, that I'm a woman, I enjoy the period, and I have the methods to keep it under check. I have a cup or whatever. Now, why should boys have all the fun? That sort of theme. So we also can have fun. That's the thing.
Right. You have covered the whole, because my next question was about the role of counseling, when it comes to menstrual, and you have rightly pointed out that counseling does play an important role. Coming to you, Dr. Nirmal-san, do you agree that, yes, counseling is, Dr. Nirmal-san, can you hear us?
Yes, please go ahead.
So what about when we talk about health equity, menstrual health and hygiene, sanitation, you think counseling can play an important role, when it is integrated at primary health level?
Definitely, yes. It is a must and it is need of the hour. So that then only they can go ahead. Because even though we are already giving in the schools, colleges, but also in the houses also. So as Sir was also telling about the other things, and we have taken the leaf out of Kerala regarding this menstrual cup. So the other team is having a phone call center to do all these things. And apart from that, Tamil Nadu under NHM and state government, we are having a 1 or 2 call center. So we will be calling them regarding any kind of questions regarding the adolescent girls and menstruation problem and other things. And apart from this, another the recent suicidal tendency amongst the adolescents, especially the girls who are appearing for the NEET and other things, and after the 12th exams, 10th exams, so that we are also having a thing. So the same helpline we are utilizing for creating awareness in the menstruation and all the other things. And the another call center we are looking at maybe for pregnant mothers, after pregnancy, after regarding lactation, all those things. So we are having call centers and all the other aspects. And apart from that, our the basic level field workers. So we used to call them as village health nurse, who will be catering around 5,000 population. And under them, Ashas also there in the remote areas. So they are directly involving in the awareness creation along with the doctors. Of course, under the NRHM, we do have the other programs like Rashtriya Kishori Karyagram. So in that thing also, the RKSK programs in almost all the districts we have covered right now. Under this, we are having a counseling program. We have found out some one per school. So for that school kid who will be trained under other activities, and she is the counselor, and that girl or boy will be giving information to the doctor, the primary health center doctor, regarding any queries or any problems to that school boys, because it is a peer educator or peer group consultation will be better than anything. So we are giving, under the government scheme, we are giving 50 rupees for the peer educator and the school health ambassadors. Training also given to the school teachers. So we are having a wide area, and the counseling through the reachable person. The counseling from the phone call center is another area. Through the doctor and paramedical staffs also another area. Through the school also another area. Maybe the self-help group, all the person. The counseling whenever they are having an ideology, because the other general public and the other persons, the free thing which everybody will be giving is go and tell some myths and unnecessary beliefs, so that it is going to have a negative impact. So at that point of time, we have to give a proper education, proper counseling, and for that we have to ensure that all the things are available for the general public to access. So that we have to do.
Coming to, since we are already running short on time, Dr. Sangamitra, your key takeaway from today's discussion, anything that you need to add to what we have discussed today, anything in the shortest number of words?
Yeah, we need to generate, we need research in 3 aspects. One is generating evidence. Another is we may be having many studies or many already data available. How do we synthesize that evidence? And what is most important, how do we translate that evidence in?
Thank you. Coming to you, Dr. Sapna.
I would agree and say women's health through the life course, looking at it from a multi-sectoral point of view and really thinking about this as an issue of equity for girls, for women, through menopause and post-menopause.
Thank you. And I can see the experts for the next session joining in. So that indeed was an insightful discussion on some very pertinent aspects of menstrual health in the country. And as rightly pointed out by the experts, when it comes to ensuring menstrual health, equity, awareness, breaking taboos, clearing stigmas, and of course, taking a life course approach is of primary importance. And thanks to all our experts, Dr. Amar, Dr. Sangamitra, Dr. Sapna, Dr. Nirmalsan, thanks so much for being a part of this Preserve the Uterus Conclave, and thank you.
Thank you. Thank you.
So moving on to the next session, I would invite Resham to take on from there. Resham, can you hear us?
Hello. Thank you for joining, everybody. We will be going forward with the second session now. So, Dr. Bejit, thank you. Resham will be
Good afternoon, everyone. Okay. So good afternoon to one and all present here. I am Resham, health journalist at IHW TV. Welcome you all to the second edition of Preserve the Uterus Conclave on redefining and empowering women's health, an initiative of IHW Council supported by Foxy and Bear, where this virtual conclave is a part of IHW Council mission, which is Preserve the Uterus. And in the first session, we will be discussing on the topic, a very interesting one indeed, which is unveiling hysterectomies at grassroots. That is, we're going to talk about the ASHA and ANM perspectives on ground reality. So let's jump in and let's begin with the very insightful session. But before starting the session and asking questions, I would just like to welcome the doctors and the ASHA workers too. So firstly, I would like to welcome Dr. Prabhudev Gora, who's the Deputy Director of EMS Directorate Health and Family Welfare Services, Arogya Soda, Government of Karnataka. Then I would like to welcome Dr. Rajesh, who is the District Health Officer at Shimoga, Government of Karnataka. Then Dr. Narendra Appa, who is the District Health and Family Welfare Officer, District Hospital, Government of Karnataka. And then I would also like to welcome Dr. Praveen, who is from District Hospital, Government of Karnataka. And I think we have introduced the doctors. So now I would like to introduce two of our ASHA workers, and we will be, of course, like I said, taking their perspectives on the topic. And one of them is Miss Mangnu Meena, who's an ASHA worker from Rajasthan, and another one from Rajasthan, who is Miss Ramu Meena. So welcome everyone on board, and I think we are done with the quick introduction. Time to start with the session. So my first question is to Dr. Prabhudev, who's, like I said, he's the Deputy Director of EMS, Health and Family Welfare Services, Government of Karnataka. So Doctor, I would like to ask you certain questions, something from your experience, that from your experience in the health department, can you highlight any successful strategies or training programs that have proven to be a big success? So I think this is one of the questions that I wanted to ask Dr. Prabhudev, but my team has just informed that he is just, he'll be joining us very shortly. So before, I think, then I will ask some of the questions to Dr. Rajesh, who has joined us. So firstly, thank you, Doctor, for joining us and being a part of the session. So my first question to you is that in your role as the District Health Officer, what measures have you been taken or have taken at the district level to monitor and regulate women's menstrual health related problems, particularly in cases where the woman and her family are considering hysterectomy?
Good morning, madam. I'm Dr. Rajesh. Thank you for inviting me for this panel discussion. Yes, there are a lot of programs which is involved which has been percolated from the state to the district and to even to our grassroots level workers. Few years back, nothing much was there for regarding about the menstrual thing. Only thing what was happening there, when it comes to woman, one child age group, and next is a tubectomy. Next after that was the hysterectomy. But of late, since couple of years, we have a lot of programs regarding for considering of the menstrual cycle of that woman. So we start initially in the start initially in the school age group, where we tell them what are, once they attend the menarche, what are the symptoms, what are the changes they could occur in their body, so that these things begins from them, right from their appearance of the secondary sexual characters. What are the changes the girl will have, and what are the myths and what things they will have. That we attend. We have got an adolescent friendly clinic which we're doing. We're training all the ground level workers for that. Second thing, what's happening now is now the woman comes to play only during pregnancy and for tubectomy. Next, what you rightly pointed out about the hysterectomy was these people, they have a cancer phobia. They think if they remove the uterus, hysterectomy is done, they're cured of the cancer. No. Most of the things which are uterine, majority of them, they have some whitish discharge, some leukorrhea, which is 100% treatable. Second thing could be that this could be uterine bleeding disorders, which is definitely treatable. It needs to be analyzed. What these people do, they go to some non-qualified persons or people who are not much having much knowledge at the rural setup. They advise, no, why don't you go for hysterectomy? So their mindset comes from there itself, from it. No, if I remove my uterus, I'll be preventing cancer. No. Now we have taken a lot of steps now at the grassroots level, where we have appointed community health officer to all our sub-centers. We have made the health and wellness centers. Every week they do a screening. Now every Tuesday we are doing health mela. Starting from this last 19th, every Tuesday we're doing health mela. And our community health officer working at the field level, we have been told to detect under non-communicable disease. They do a screening for diabetes, hypertension, oral cancer, breast cancer, and cervical cancer. So these are the things which you tell them. All it requires the woman is to be educated what are small things, changes which is occurring with her, and if it is 100% treatable. So what is the best option is to get thoroughly checked up by a qualified gynecologist, very and repeatedly follow up, and timely treatment will go in a long way to where we can avoid this unwanted hysterectomies. Unfortunately, what's happening now is the hysterectomy is becoming the first option, where there are other options, where it should be the last option. If there is leukorrhea, whitish discharge, it is 100% treatable. All they have to do is speculum examination. If they repeatedly look, they could do a pap smear, screening for cancer, cervical cancer. Or next, they could, second things, we go for a uterine bleeding disorder. There are 7 to 8 conditions. They're all treatable. And they can do ultrasound guide and very regular follow-up, and plus timely medication will definitely be going a long way in avoiding this unwanted hysterectomy done. This we have given a lot of training to our field staff, where we have educated a PSO, primary healthcare provider also, and community health officer also, senior inspection officer, and ASHA worker, special ASHA worker. So now the thing is, now hysterectomy is not the only option. Hysterectomy, garab kosha tegide vade option alla. There are a lot of things. Hardly out of 100, 1 or 2 might require hysterectomy. So we are avoiding from 90 to 95% of the hysterectomy. Recently, our department had conducted an inquiry against one person who had done a lot of hysterectomies. I know a couple of hysterectomies. I've seen some people. A woman gets, she at puberty, menses starts, so she has some disorders like pain abdomen. So the gynecologist treats her, and after this she gets married. Child conceived, some other treatment is given, after delivery is done, and after tubectomy, after 4 to 5 years, they say hysterectomy. So that person become complete family man for that lady, complete family physician. Now this should be avoided. Where we need to tell that woman what could be done and what are the better options to. We have got a lot of baskets of other measures. So these things should be made open to the lady and let her choose what is best for her. Hysterectomy is not the only option for them. There are a lot of options. This is what we do, a regular meeting, we do our NCD camps, where we tell them. So cervical cancer screening is our topmost priority. So we have been in touch with them, where we tell you, so unwanted, we are trying to avoid the hysterectomy, sir. But basically what I could say as a DHO, and with this experience, what I could see was, they're mainly bothered about the whitish discharge, treatable. Second thing, some uterine bleeding disorders, these are treatable, and regular pap smear, abdomen scanning. This we are trying to motivate, and basket of all the things, all the programs which are available is made available to that lady. Let her make her own choice.
Yes.
Choice should not be coming from the top. She should be ready. Yes, when I'm ready to treat the patient, right? So I should be given the option should be given to the lady. That's the thing, madam, from my side.
So, doctor, as you rightly pointed out that the option should be given to the lady, could you suggest some of the alternatives, like a quick alternatives other than hysterectomy that a lady can go for?
See, most of them, see, like I said, this is called whitish discharge. This is a common thing. They have repeatedly food burning and some burning, which is something. They think there's something wrong with the uterus, where probably the first thing which they come to know that it's a cancer. There's a cancer phobia. They think it's a cancer. If I get my uterus removed, I'm free. No. We need to tell the lady, we need to counsel her and tell that lady it is treatable. Regular follow-up is important. And be under good guidance, doctor. So these things we're trying to motivate. Second thing, bleeding. All bleeding does not require hysterectomy to be done. Yes. There's 78 conditions. There's 78 conditions where it could definitely be treated. And regular pap smear, regular screening for cancer. That's the option. The option should be given, and we should be not. And these options are almost available at the village itself. They don't need to come to the district or taluka headquarters. This we are doing it at all the sub-centers. This screening is done every week at all our sub-centers. So the things are available at the nearby our health facility. So these are the things we're trying to promote from our department. Now the thing, my only thing, what I'm telling our community health officers, what are all the things available that the person should be made known to it.
Okay. Yes. I think you rightly pointed out some of the points. Firstly, that the woman should be able to make a choice. Then I think I'm going to ask my next question from Dr. Narendra Abba, who is the District Health and Family Welfare Officer. So firstly, I think he has joined. Yeah, he has joined. So, Dr. Narendra Abba, I would like to ask, put across a question that as the District Health and Family Welfare Officer, what approaches have been effective in ensuring healthcare facilities to prioritize women's reproductive health and something, the women reproductive health needs are adequately met or not? Dr. Narendra Abba, are you on board? I think Dr. Narendra is not in the session. I think he's left for some time. So I think now we have taken doctor's perspective, Dr. Raj's perspective about hysterectomies and what the woman should be able to make a choice. He has rightly pointed out some of the points. So I think now I'm going to ask a question from one of the ASHA workers. We would really want to know her perspective as well. So Mangu, Meena, I would आप ज्वाइन करेंगे. मैं आपसे कुछ सवाल पूछना चाहूंगी. आपको मेरी आवाज आ रही है? आपको मेरी आवाज आ रही है? मनगू मीना जी, आपको आवाज आ रही है? आपकी आवाज नहीं आ रही है. आपका शायद माइक. मीना जी, आपकी आवाज नहीं आ रही है. I think there is some disturbance while we are trying to connect with the.
Hi, Resham. So I believe there is some network issue at Mangu Mina's end. So what we can do is I will connect with her over phone, and then we can have your questions with her.
Sure.
Yeah, so I will just connect with her. हाँ जी, मंगू मीना जी.
हाँ मैडम.
जी, आपसे ये क्वेश्चंस पूछेंगे, आप प्लीज आंसर कर दीजिए ऐसे फोन पे, ठीक है?
ठीक है मैडम। वो क्या जवाब, मेरा इधर आवाज ही नहीं आ रही।
नो प्रॉब्लम। ये अभी आपसे पूछेंगे तो आप यहाँ पे बता दो।
ओके।
हाँ, तो पहले तो आपका स्वागत है हमारे सेशन में, मंगू मीना जी। थैंक यू, आपने हमारा सेशन ज्वाइन किया। आपसे इससे हम बहुत सारी चीजें, आई एम श्योर हमारी ऑडियंस सीखेगी और बहुत जानेगी भी। तो पहले तो मैं चाहूंगी अब अपना, हमारे ऑडियंस को अपना नाम बताएंगे और ऑल्सो जो क्षेत्र बताएं जिसमें आप काम करने के लिए नियुक्त की गई हैं।
हाँ।
आपको मेरी आवाज आ रही है?
मंगू जी वो पूछ रहे हैं कि आप अपना नाम प्लीज बताइए सबको, और आपको कौन से क्षेत्र में नियुक्त किया गया है एज आशा वर्कर, वो भी बताइए।
मैडम जी, मेरा मांगो मीना नाम है और मैं पीएससी देवगढ़ और गांव कमलाकुड़ी में काम करती हूँ।
अच्छा, ठीक है मीना जी। आप ये बताएंगे कि आप एक सप्ताह में कितनी महिलाओं से मिलती हैं, उनका चेकअप करती हैं?
मैडम जी, 30 महिलाओं से मिल जाती हूँ मैं इस सप्ताह में।
30 महिला। तो ये कभी जो ये आंकड़ा है, ये कभी बढ़ता भी है, कम भी होता है?
हम्म।
जी। सो आप जिन महिला का इलाज करती हैं उनमें मासिक धर्म यानी पीरियड संबंधित कौन सी समस्याएं आपको सबसे ज्यादा देखने को मिलती हैं?
मैडम हमारे इधर तो अभी इतने तो नहीं मिले, पर ये मासिक धर्म आने में तो ना, ये वाली बीमारी कभी सफेद पानी जाता है, ऐसी महिला कोई मिल जाती है।
अच्छा, और कोई जो सबसे ज्यादा आपको देखने को मिलती है, स्पेशली जो जो थोड़ी मिडिल एज, जो थोड़ी बूढ़ी महिला है या फिर यंग जो छोटी बच्चियां हैं, उनमें कोई अलग आपको देखने को मिलती है जो आपने नोटिस किया हो, ये गौर किया हो?
मैडम जी, कोई महिला ऐसे भी मिलती है कि पीरियड के टाइम में दर्द होता है।
हम्म।
दर्द वाली मिलती है।
अच्छा। सो जिन महिलाओं को भारी मासिक धर्म होता है, लाइक हैवी ब्लीडिंग होती है, उन महिलाओं के लिए आप क्या सलाह देना चाहेंगी? क्योंकि आई एम श्योर ये
उनको तो
केसेस तो आपके पास आते ही होंगे।
हम उनको ज्यादा अधिक तो रक्त स्राव हो रहा हो तो उनको हम हॉस्पिटल के लिए भेज देते, रेफर कर देते।
क्या आप क्या करती हैं, एक बार आप फिर से दोबारा बोलेंगी?
मैडम अधिकतम हो रहा है उनके टाइम पीरियड में, तो फिर हम हॉस्पिटल के और उनको भेज देते हैं।
अच्छा, आप हॉस्पिटल के वहां भेज देती। अच्छा। सो आप क्या दी गई सलाह अपने अपने अनुभव से है, या कुछ आपको गाइडलाइंस यानी दिशा निर्देश है जिनको आप पालन करती हैं, जो आपको ऊपर से बताए जाते हैं आप उनका पालन करती हैं, या आप आपके एक्सपीरियंस या अनुभव से भी आप कुछ चीजें इन औरतों को बताती हैं?
ये बताना चाहिए, हम ऊपर से सीख के आते हैं।
अच्छा, आप सीख के आती हैं सारा। अ, मीना जी, आप सुन पा रही हैं?
हाँ।
हाँ। सो ये जो दिशा निर्देश हैं जो आपने बोला कि आप सीख के आती हैं, आपको ये कब प्रदान किए जाते हैं? क्या आपको बार बार ये सिखाया जाता है, या एक बार आपको सिखा दिया गया है, आप उसी को फिर सारी महिलाओं को, जो भी पीड़ित महिला है, उनको बताती हैं?
नहीं मैडम, हम बार बार सीखते हैं, उनको पीएससी जाते हैं और बार बार सीख के आते हैं, ये इनके बारे में बात करते हैं।
अच्छा। तो अगर जैसे कोई चीज है, कोई महिला आपके पास आती है और अगर आपको उनका वो समझ नहीं आता है कि उनकी प्रॉब्लम क्या है, तकलीफ क्या है, तो आप फिर उससे कैसे डील करती हैं? फिर आप क्या, आपका नेक्स्ट स्टेप, आपका अगला कदम क्या होता है?
मैडम हमारा अगला कदम तो या तो फिर हम पीएससी पे भेजते हैं या फिर नाम दीदी को बोलते हैं।
अच्छा। और क्या आपके गांव में महिलाओं को इलाज समझने के लिए किसी फोन या पैम्फलेट का आप इस्तेमाल करती हैं, या फिर मुंह जुबानी ही सब चीजें समझाती हैं?
मैडम हम घर घर जाके समझाते हैं उनको।
अच्छा, घर घर जाके समझाती हैं।
हाँ।
हाँ, तो अभी भी क्या कुछ महिला ऐसी हैं जो थोड़ा शर्माती हैं, आगे नहीं आती हैं अपनी मासिक धर्म के बारे में बात करने, या अब थोड़ा बदलाव आपको देखने को मिल रहा है?
मैडम अभी तो ऐसे महिलाएं मिलते हैं जो शादी नई नई शादी वाली है, तो हम उनको नए तरीके से सिखाते हैं, उनके धीरे धीरे पूछते हैं, फिर बता देते हैं।
अच्छा, जैसे आपने बोला नई नई शादी वाली है, वो अपनी जो दिक्कतें हैं वो बता देती हैं, जो बट आप उनके बारे में बताएंगी जो अभी जिन बच्चों को अभी मासिक धर्म ये शुरू हुआ है, तो उनका क्या वो खुल के चीजें अपनी प्रॉब्लम बता पाती हैं या नहीं, या फिर आप कोई और अलग तरीके से उनको समझाती हैं?
मैडम वो फर्स्ट में होता है तो वो इतना तो नहीं बता सकती है, पर उनके मम्मी को पता चल जाता है, फिर वो मम्मी हमको बताती, फिर हमको उनको बोलते हैं कि बेटा ऐसे करना, ये साफ सफाई रखना और पेट के।
अच्छा, और जिन जिन महिलाओं का जैसे मासिक धर्म बिल्कुल खत्म होने वाला है, जिसको फॉर द व्यूअर्स मेंस्ट्रुअल साइकिल खत्म होने वाली है, मेनोपॉज आना है, तो जैसे मैं आपको बता रही हूँ कि जिनका खत्म होने वाला है मासिक धर्म, तो उन क्या वो आपके सामने खुलकर आती हैं अपनी दिक्कतें बताने, क्योंकि सबसे ज्यादा कहीं ना कहीं उन्हीं को दिक्कतें उस टाइम पे फेस करनी पड़ती हैं, तो क्या वो वाले केसेस भी आपके पास आ रहे हैं अभी या नहीं?
नहीं मैडम, जो आती भी है फिर हम उनको जाते पूछते तो बता देती।
अच्छा, ठीक है। तो थैंक यू, धन्यवाद मीना जी, आप हमसे जुड़े और आपने हमें ग्राउंड रियलिटी अपने गांव से बताया कि क्या क्या चीजें हो रही हैं और क्या क्या एक्चुअली में चल रहा है। हमसे जुड़ने के लिए थैंक यू सो मच। So I think we really got a very good perspective from one of the ASHA workers, which is Meena. Thank you, आप हमारे साथ जुड़े।
Yes, Resham, thanks. We got to know the perspectives via the brilliant interview that you did. We have another ASHA worker, Ramu Meena ji, who will also, I will connect with you so that we can have her inputs on the same as well. Just give me a few minutes. Until then, you can take questions from our medical experts, and once I have connected with her, I will update.
Okay, that'll be great. I think my next question will be from Dr. Praveen. Dr. Praveen has not joined our session again. So I think I would again want to ask one question from Dr. Rajesh. Yeah. Okay.
Yes,
so,
ma'am.
Yeah. So, Dr. Rajesh, I would like to ask that what recommendations would you offer to improve the accessibility and availability of alternative treatments or inventions for uterine health within the district when we're talking about it?
Madam, regarding this program, I have told you before, this program is taken up at the grassroots level, at the sub-center level. You should know that one sub-center is a functional unit of a primary health care. So one PSC, primary health center, will have 3 to 5 sub-centers. So each sub-center, we have provided the community health officer, where we have trained them to educate these people. And plus, we have adolescent-friendly clinic we are doing there. Plus, we are doing counseling. Third thing is each and every PSC, we are telling to have a clinic. The Sneha clinic or the kitchen now is to reach his general. So the only thing is, our main primary concern is that to pick up the things at the earliest. Second thing is create an awareness such a way that everything hysterectomy is not the only answer, where there are a lot of other things available. So our thing is another small, like I told you before, like whitish discharge, some foul smelling discharge, or pruritus, or some itching, or burning. These are all treatable. There could be other conditions for that also, because so we are trying to, and like plus second thing, what happens is that at the primary health centers, some on a syndromic approach based on the symptoms. Sometimes we put the treatment, what we call a syndromic approach. So at the PSA level itself, we can take care of the small which is correctable at the PSA level. Second thing, if the woman is having repeatedly, we refer them to our higher centers where there is obstetrician. So we have got a referral system. So all these cases, what we are seeing is we update online. Online. Plus, if the treatment is not available, even at our taluk or district hospital, we can refer them to Ayushman Bharat for further treatment if it is not available in our health facility, government health facility. So these are all the things which we are doing. Our mainly focus is the girl at a time of puberty. She should be knowing what are the changes will be occurring to her. First thing what I've seen, first thing what is it? Childbearing age group should be increased. Now 18 years, they said 21 years. What I have personally seen in my district, children with two children, lady with 2 to 3 children, they come for a tubectomy, sterilization operation. The mean age is just 23 years. Just 23 years. And I've seen all the hysterectomy which are occurring, they're almost between 30 to 35. Where it's a God-gifted thing, where a reproductive option is a God-gifted thing, a female is blessed with the organs to. So we should do in all our capabilities with all our resources to preserve the uterus. That should be that's our main goal. This is what I'm trying to tell. I go further and tell my field staff, will a male do his sterilization operation? The same thing what we do for hysterectomy, will a male do it? No. Why? Why are all our programs are only female based? We should educate our female staff also. Our people also should be educated. Suppose if there is some issue in the family matter, the husband also, you should take the equal responsibility. I had asked these questions too many times. So many times during my meetings also. See, I asked the lady also, I asked the male partner also. Now, are you ready? You say hysterectomy. Or you say tubectomy. Why can't you go for vasectomy? Why only the female? Why only female? Are our programs only female oriented? We also got a lot of programs even for male also. Other thing. So as a district health officer, our role is all the female organs, genital organs, they should be preserved. It's a God gifted. We need to preserve it. Removing it should be the only last option, which taking care of the male. And plus, what happens after hysterectomy? There's a lot of hormonal imbalance. They land up with other causes. Plus, she sees that, and I got my uterus, and I think there could be some other things where she could be mentally affected also. So we need to take a lot of things. So we need to do counseling. Counseling is the main part. So the girl right at the puberty, childbearing age group, and other options. So now what has happened? We are seeing 2 children, mean age in our district for tubectomy done solution is around 23 years. I just tell them, uniform to this ladies looks like a college going students. Now they're coming for the families completely, they're coming for a tubectomy. Why can't it be done 28, 29? Why can't it be spacing? So these are all the things we are going. So I know, because this what we have been discussing about the preservation of the uterus. Yeah, it needs to be taken in a very, very big way, and we need a lot of other support also. All people at the grassroots level need to sit there, and we have our villages and nutrition day every third week. The ASHA conducts a VHD, village health and nutrition. So where we tell this about this, what are all the options open? Only one thing that this should not start at only at 30, 35. It should start at I feel when they come to the school level, 8, 9, 10, the girl need to know human anatomy. They need to know. So anything like this, thank you for sharing this thing with them, because what has been happening in the field. We have been trying to take it in a very large way, but unfortunately, what's happening, we need still more support from other private organizations to come and be a part, where we could go to the public and tell these things. So a lot of IC activities has to be done to promote, to avoid hysterectomy. So at field level, yes, other programs were well advanced, but regarding this, somewhere it is not reaching up to a respected level. So we need to change the mindset of the lady. That's what I could make out from my being as a DHO here.
Yes. Doctor has rightly pointed out, we really need to know and of course put a lot of thinking when going for hysterectomies, because like you said, it is the last option according to you. I think now again, Asabi, I think we can connect to one of the ASHA workers now.
Yes, hi Resham. We have Miss Ramu Meena here with us.
Yeah.
So you can start taking her questions in Hindi, please.
Okay. मीना जी, आप मुझे सुन पा रही हैं? सॉरी, रामू जी, रामू मीना जी,
आपको सुनाई दे रहा है? हेलो,
हाँ मैम, सुनाई नहीं दे रहा है।
हाँ जी, रामू मीना जी, आपको आवाज सुनाई दे रही है?
हाँ जी मैम।
हाँ, तो आप हमारे ऑडियंस को अपना नाम एक बार फिर से बताएंगी और ऑल्सो अपना क्षेत्र बताएं जहां आप काम करने के लिए नियुक्त की गई हैं।
रामू मीना जी, आपको आवाज आ रही है कंप्यूटर से?
कंप्यूटर से आवाज नहीं आ रही है मैम, आप बोल रहे हो आवाज आ रही है।
अच्छा, कंप्यूटर से आवाज नहीं आ रही है। ठीक है, मैं आपको नॉर्मल कॉल पे कनेक्ट करती हूँ। यस, रामू मीना जी, आपको आवाज आ रही है?
हाँ जी मैम, आ रही है।
जी, मेरी आवाज आ रही है आपको रामू मीना जी?
हाँ जी, आ रही है।
हाँ, तो रामू मीना जी, आप हमारे दर्शक को अपना नाम अपने जुबानी बताएंगी और ऑल्सो आप काम करने के लिए नियुक्त कहाँ की गई हैं, कौन से क्षेत्र
जी मैम, सब सेंटर सिकलाड़े, पीएचसी देवगढ़, ब्लॉक दमोतर, डिस्ट्रिक्ट प्रतापगढ़।
अच्छा, और रामू मीना जी, आप हमारे दर्शक को बताएंगी कि आप एक सप्ताह में कितनी महिलाओं से मिलती हैं, उनका चेकअप करती हैं?
एक सप्ते में 15 से 20 मैम।
15 से 20, अच्छा। सो आप जिन महिलाओं का इलाज करती हैं उसमें मासिक धर्म यानी पीरियड संबंधित कौन सी समस्या आपको सबसे ज्यादा देखने को मिलती है, जो
अधिकतर 30 से ऊपर वाली जो महिला है, इसमें हर महिला मिलती है मैम।
क्या दिखती है, फिर से बताएंगे प्लीज?
मैम, वो वाइट डिस्चार्ज ज्यादा होता है उनमें से, अधिकतर वही ज्यादा समस्या रहती है।
अच्छा, अच्छा। और फिर भारी मासिक धर्म यानी ऑडियंस के लिए फॉर ब्लीडिंग, द हैवी ब्लीडिंग से पीरियड महिलाओं के लिए आप क्या सलाह देती हैं, जिनको बहुत ज्यादा हैवी फ्लो होता है या बहुत भारी मासिक धर्म होता है, उनको आप क्या सलाह देती हैं?
मैम, ज्यादा साफ सफाई के बारे में बताते हैं और ज्यादा हो तो फिर हम साथ में जाते हैं, इलाज के लिए ले जाते हैं उसको।
अच्छा, आप उन्हें खुद इलाज के लिए ले जाती हैं या फिर आप उनको कोई पता देती हैं, हॉस्पिटल का नाम बताती हैं या फिर?
साथ में जाते हैं हम।
अच्छा, सो क्या जो भी आप उनको सलाह देती हैं वो आप अपने अनुभव से देती हैं या आपको कोई दिशा निर्देश यानी कोई गाइडलाइंस दी हैं जिनका आप पालन करती हैं?
नहीं मैम, गाइडलाइन नहीं है, हम हमारे हिसाब से देते हैं।
हाँ, अपने अनुभव से देती हैं। जी, अच्छा। सो ये जो दिशा निर्देश है, मतलब आपको कोई और दिशा निर्देश मिलते हैं कोई रोजाना तौर पर, या फिर आपके पास कोई आता है आपको सिखाता है कि आपको ऐसे करना है और अगर ये दिक्कत है तो वैसे किया जाता है, मतलब आपको रेगुलर बेसिस पर दिशा निर्देश मिलते हैं या नहीं?
मैम ऐसा तो नहीं, हम जब पेशेंट को लेके जाते हैं उस समय हमारे डॉक्टर जो वो देते हैं सलाह।
अच्छा, फिर अगर आपके पास कोई महिला आई और आपको नहीं समझ आता है उस वक्त पर कि आपको क्या करना चाहिए, तो फिर आप क्या करती हैं? उसके बारे में आपको शायद जानकारी नहीं होती होगी, ऐसी बहुत सी चीजें होती हैं, तो फिर आप नेक्स्ट आपका क्या कदम होता है?
मैम ऐसा होता है तो हम हॉस्पिटल डॉक्टर को ही दिखाते हैं और कुछ नहीं करते।
अच्छा, और आपको दिखा, और क्या अभी जो औरतें हैं जो आपके पास आती हैं, क्या वो और खुलकर आपसे बात कर पाती हैं, या अभी भी उनको थोड़ा शर्म आती है आपसे अपनी दिक्कतें शेयर करने में, बताने में?
शर्म आती है और बताती है मैम।
बताती हैं। और जैसे अभी हमने मनगू जी से बात की थी, तो उन्होंने बताया था कि जो जिनकी अभी नई नई शादी हुई है वो थोड़ा शर्माती हैं थोड़ा अपनी दिक्कतें बताने में, तो क्या आपने भी ये चीजें फेस करी हैं?
वो नई नई शादी है वो नहीं बताती है।
अच्छा, वो नहीं बताती हैं।
हाँ।
अच्छा, और जैसे मैंने मंगनू जी से भी पूछा था, तो कि जब जो महिलाएं जो जिनका मासिक धर्म पीरियड्स जो है वो खत्म होने वाले होते हैं, जो बिल्कुल लास्ट स्टेज पर होते हैं, मेनोपॉज जिनको बोला जाता है, उस पे होते हैं, तो क्या वैसी औरतें भी आपके पास आती हैं अपनी दिक्कतें लेकर, या वो सारी चीजें या केसेस आपको नहीं देखने को मिल रहे हैं? जिन औरतों के जो मासिक धर्म है वो खत्म होने वाले हैं, जैसे बोलते हैं ना लास्ट स्टेज पर है, जो 55 या 50 की उम्र की महिला है, तो क्या वो भी आपके पास आती हैं अपनी दिक्कतें लेकर, औरतों वाली जो दिक्कत होती है, या फिर वो चीजें आपको नहीं देखने को मिलती हैं?
नहीं आती है मैम, एक महिला भी आती है।
आती हैं और खुल के आपसे बात करती हैं?
हाँ वो तो खुल के बात करती है। जो नई नई लड़कियां हैं वो नई शादी करके आती है, वो बताने में थोड़ा शर्माती है, बाकी वो बड़ी औरतें हैं उम्र वाली वो बता देती है।
अच्छा, सो क्या आप गांव की महिलाओं को इलाज समझने के लिए किसी फोन या पैम्फलेट का आप इस्तेमाल करते हैं, या मुंह जुबानी ही सब चीजें बताती हैं? कि आप जब अपनी जो महिलाओं को चीजें बताती हैं और उन्हें सिखाती हैं, तो आप क्या कोई फोन या पैम्फलेट का कोई इस्तेमाल करती हैं, या सब बोल कर ही सब चीजें समझाती हैं?
नहीं हम बोल कर ही समझाते हैं।
अच्छा, अच्छा। तो आई थिंक वी हैव टेकन ऑल द क्वेश्चंस। पहले तो थैंक यू रामू मीना जी, आप हमसे जुड़ी और आपने बहुत सी बातें हमारी ऑडियंस को सिखाई, हम मुझे भी बताई पर्सनली। थैंक यू, आप हमसे जुड़ी। Yeah. So I think now we have Dr. Narendra Appa on board. He's also one of the health experts. So, Doctor, can I ask you some questions? Dr. Nagendra Appa. I think he's still not joined. So I think now again we are going to continue with the Dr. Rajesh. Okay, so Dr. Rajesh, you pointed out about the counseling sessions, you advised people to go for counseling session, and something that you go for. So is it actually effective, and does it actually work? Doctor, your mic is off.
Yeah.
Yeah.
Madam, definitely it will work. It will definitely work, because lady knowing the options with her, what are other things, definitely work. We need to go see the counseling can't be done it can't be done in one setting. It will need to have multiple settings. Probably first or second she might not talk. By the third or fourth counseling, probably she might make up her mind. Yes, I will do that. I will do that. Third thing, we need to educate the family members also. Even the partner also should be told the options. So definitely counseling plays a very important. Plus what's happening, we need to have a lot of IC activity needs to be done. A lot of it. So we need to have regularly talks. We need to have regular. We have got Radio Shumoga. So where I address a lot of things through radio, because viewers, there are a lot of people who come for the viewerships. They listen to the program. Hello, am I audible?
Yes, doctor, you are.
Yeah. So a lot of IC needs to be done for this, madam, because see, health services at the rural setup and the urban setup, what I've seen, 30% of our population is in the urban, 60% is in the rural. So if you take the doctor-patient ratio, it's very high in urban, which is very low in rural side. So we need to have a very big force, because it is not only the health department, it's all the private persons also. Foxes should take up a very good, should take up this this campaign. It should be fought in like on a war footing basis. It should be fought like that way. It needs to be done. And plus, what happens is that most of the, I'm sorry to say that most of the hospitals, they become commercialized now. They become commercialized. So some might think that they might lose their business if you propagate this. They might lose. So a lot of things also is involved in that. So I don't think it's very tough, but I think we need to go in a very big way, and it takes some time. It definitely takes some time, because educating the mothers, it will take time, because they need to understand the things and what are the things available at their level. It will take some time, but it should be a persistent, and a persistent activity should go on. It's not that we do a campaign and then stop it. Like we do a lot of national programs where we have all other WHO also coming with a lot of other World AIDS Day, Blood Donation Day. They do for 1 day or 2 day do activity of 50 days video campaigning. Like we did for last month, we did for malaria, dengue. So 1 month we just kept on speaking about the dengue and malaria. But this should be uninterrupted and uninterrupted topic. So at the end of any discussion, right, at least you should end up with few words regarding the menstrual hygiene of the lady. Few words should be told.
So, doctor, like you pointed out that somewhere or the other, it has become like a money business. So, like, whom to trust now? Like, if I'm going to a doctor, if I have a problem, then how can I trust the doctor? Like, I can, of course, go for second opinion, but maybe the second doctor is also recommending.
Now I'll tell you, madam, what happens. Now most of the patients have become Google doctors.
Yeah.
So if a doctor gives a prescription, they go to the Google, why not prescribe that drug? So prescription of drug depends from doctor to doctor. One doctor might like to treat the patient with particular set of drugs, but antibiotics, but other. So it varies from doctor to doctor. So now the people, I don't think so. They are so much back what it was 5 to 10. They know. They go. So Google is one thing. What we feed in the mobile, that shows. So we need to propagate a positive message to them. Positive message. Yeah, hysterectomy. I've visited a lot of nursing homes where we have even in districts where under Karnataka Private Medical Estimates Act, where we are told that they have to display the rates or what they are charging. They can't just charge anything. What are the services they are providing, and what the doctors are there, and what is their rates? That should be discussed in a public place in the hospital premises. I think hysterectomy, I have seen going between 30 to 35, the people who thinks that they are more prone for cancer during that age group. They say, once you remove the uterus, that I'm free from that cancer. So what I have seen that for all small treatable, medically treatable conditions, hysterectomy has been advised. So what it's ill advice. So we doctors also, we specialists also need to do much more to them. So like now I'll tell you. If you go to one nursing home, the lady is not ready to bear the pain. She said, no, doctor, I don't want that. You do a cesarean section. And next, further, what they like to do it on a very particular movement. The child should be done on this time. It's a God-gifted nature to the woman, where a woman should deliver on her own as per the natural process. Same thing. So now what we are telling, go for normal delivery, and then if not, then cesarean should be the last option. So same thing is this way. Definitely, it will take some time, but definitely we are at it. But because prevention of cancer is
Yes, doctor. Yeah, so I think Dr. Praveen has joined our session. So firstly, thank you, Dr. Praveen, for being a part of the session. So my first question to you is, Dr. Praveen, am I audible?
Yes, madam.
Yeah.
Yes.
So, yeah, okay, doctor. So from your perspective, how can Ashas play a more active role in educating and also advocating for alternative treatments or preventive measures for women who are actually going for or going towards hysterectomies?
Yeah. Madam, first I wanted to mention, I'm audible, madam?
Yes, yes.
Am I audible?
Yes, yes.
Most of the time, most of the people, they come with the white discharge and they want get hysterectomy for the white discharge. So they think because of white discharge, they are losing all the stamina, their energy, everything. So first thing is the ASHA workers and ANM should educate them about what is actually white discharge, what is normal physiological white discharge, and what are the facilities available if there is if the pathological discharge is there, what medical line of treatment we can give, and for other things other than physiological discharge and infective discharges, if there is something like chronic cervicitis, congestive cervix, then there are other options are available like cryotherapies, and we can try even cautery. Those facilities we can try before going for the hysterectomies. And as such, white discharge itself is not an indication for hysterectomy. The ASHA workers and ANM should educate them, especially in this aspect. And coming to this one, irregular cycles, most of the women, if they come for irregular cycles, they feel that they should get hysterectomy for that because their nuisance will come down. So we should educate them that there are irregular cycles commonly occurs during menopausal age, perimenopausal age, perimenopausal period, and during post-abortion, and if there is any hormonal disturbances. And there are many other therapies are available for these irregular cycles, like medical line of treatment, hormonal therapy, and other minute surgical procedures like DNCs. So then if it doesn't, if she get, if it doesn't cured with this one, the last result we can go for is hysterectomy. And this is the ASHA workers have to educate in this aspect. And the third aspect we do hysterectomies for most of the time is for the prolapse. For the role of ASHA workers plays a major role. That delivery should be 100% should be in the institution itself, and premature beginning should be avoided, and strict photograph applying at the institutions, and avoiding early marriage and educating the people in respect to the high-risk pregnancies. This will help in preventing the prolapse cases. And should be hysterectomy, and service should be sought if any problem is there. Should be from a gynecologist rather than a surgeon, because all the reproductive problems will be addressed best by the gynecologist, and most of the time the hysterectomy would have been done by a surgeons in most of the peripheries. So that should be avoided, and they should educate, ASHA workers should educate people to consult the gynecologist.
Okay. Okay. So, doctor, as you rightly pointed out, that ASHA worker in extreme cases, of course, should tell the people to consult a gynecologist. So my next question to you is, can you share some of the insights on any specific challenges or difficulties or barriers faced by the hospital level? Like now you talked about like the plight of ASHA workers. If you could talk about the barriers faced at hospital level when it comes to preserving women's uterine health.
Yeah, most of the time the woman has been advised by some quacks or some other than the medical persons for white discharge to undergo hysterectomies. And for irregular bleeding also, they will advise for the hysterectomies to get it done for the hysterectomies. So we feel, even because at local level, they are good patient. So whatever they tell, the patient will believe that one. See, for white discharge, if the person tells that you will lose the stamina.
Dr. Praveen. I think there was a network error. Dr. Praveen, have you joined again? I think Dr. Praveen will be joining soon. I think there's a network error. So, Dr. Rajesh, my last question to you is, if you could just briefly elaborate on the cancer phobia that you talked about and have been talking about since the beginning. The cancer phobia that is there on the women out there.
My previous speaker, what he very pointed out was the easily available doctor at the website, the majority of them are quacks, or they don't have much information about these problems, about this treating of female patients, or there is anything concerned with uterus. It has become such a thing that once you remove the uterus, which you cure of uterine cancer, that has become a victim, like almost a victim. This need to be addressed in what we need to do is we need to regulate our medical practices act. Where changes in the place, you need to check. So the unauthorized people are not supposed to treat. First, stop adequate removal. Second thing, stop adequate removal. Second thing is, like our panel doctors just spoke there. Let the obstetricians and gynecology, let them do their job. The general surgery operating on the especially it should not done because these people are the qualified person. They know how to treat a lady. Surgeon doesn't know much. What he can do is just this should be the first. We need to do this phobia, this cancer phobia, we need to tell them, see, not all discharge, not all bleeding disorders are cancer related. There are a lot of other remedies, other treatment available, medically treatment available, and surgical treatment available, which only obstetrician and gynecologists are supposed to do it. So people who are the specialists, they should do the specialist job. We at the primary health center, we need to educate our people, our field staff, let them know, let them have a group discussion. Like I told you, we have a village health institution day. Every third Saturday they have. So they, most of them, when they gather, they discuss about the problems. You can address that level also. Lastly, what I would like to tell you, one common message which I would like to put across all the people who are listening to that. As far as possible, uterus should be preserved as far as possible. Removal of uterus does not end up. It might be cured of that cancer phobia, but still end up in other mental illness, other type of mental illness. There was a lot of hormone imbalance, her thinking. This should not happen. So the big thing I want to tell you that people doing very good work at their own show also, where I will direct contact with them. And they need to sit with our health department people, not at the district level, at the state level also. They need to sit formulate one guidelines or some guidelines and orders which should be done at the state level. It's a policy matter. The policy matter only the top bureaucrats or some people sitting there should not. For policy to take a good road in this, which I personally feel that they are doing a very good job in our India. Especially what they have done, what we have seen in some case prevention of mental health that during labor. We have had a lot of training programs, they come and train our peripheral doctors. So we need to go in a group in a collective manner, become common goal, and this is a policy matter which needs to be addressed at the state level. I think Fortune should now pick up the leading role in making this policy is done and program implemented.
So, like you pointed out, Dr. Rajesh, uterus should be preserved, and that was your final words. Thank you so much, Doctor. I think now we will talk to Dr. Praveen. So, Dr. Praveen.
Yeah. Yes, ma'am.
So, Dr. you were talking about the challenges and difficulties in the negotiation.
Yes. Especially in the local person who advise hysterectomies. Usually, the patient is being very good in terms of the local person. So, whatever he advises, hello, I'm audible, madam? Hello? Yeah, okay. Because whatever he advises, so they follow the same thing. It is very difficult to change the patient mind because they will listen to the local person's advice in a better way. So I think I should educate them and about the things of what are the things what cases they have to go to what cases they can take the medical treatment and in what cases they don't need hysterectomy also. This is the area the hysterectomy role play a major role. And another one is there are some cultural taboos are there. The lady menstruating is made to sit outside the village for 3 to 5 days and then hygienic hut. So it makes them go it helps them rather than make it compels them go for hysterectomy for this reason. So as a NGO organizations or ASHA workers and district level, we should educate them that it's not going to cause infections and this culture would be removed. Because there are many areas in our and taking them in confidence definitely love
Okay. So, Doctor, if not hysterectomy, what are the alternatives that are suggested to do there? If not hysterectomies, if you could talk about the alternatives.
Yeah, definitely depends on the conditions. See, if the kind of patient is having acute PID or PID, pelvic inflammatory diseases, then definitely we can give them antibiotic therapies. If there is any chronic cervicitis is there, then we can go for the cryopreservation, even the cautery, and even minute, even the conizations. And if there is white discharge is there, the infective one is there, we just treat the infective cause, whether it may be bacterial vaginosis or trichomoniasis or candidiasis, you treat them, build the immunity of the people, women, because anemia is also one of the reasons which causes debilitating conditions for the mother. So you build her this one iron hemoglobin status, build with give her good protein, high protein, and in case of abnormal uterine bleeding, so you can counsel the patient the nature of the menstrual cycle and hormonal changes which can occur during the post-abortive stages, during perimenopausal stages, and you start giving oral contraceptives, or you can go for the Mirena also. And we can also educate the people for the small fibroids, they don't cause cancer, and there is no need of hysterectomies in those cases also. And for coming to the CS cervix, pap smear examination, educating people or women for the pap smear. And nowadays we are coming with the visual inspection, acetic acid, counseling the women women to undergo visual inspection or stick acid. Now it is being done even at the sub-center level by the public health officer. So, and immunization to the HPV vaccine to the during between 9 to 11 years. And nowadays, in the Indian context, we can give up to 26 years, till the within the period of that she has exposed to the fighters. So these are the things we can do. Treatment we can give other than hysterectomies.
Okay, so as rightly pointed out, thank you, Dr. Praveen, for joining us. And thank you all the health experts and ASHA workers for sharing the insights. I'm sure our audience and I have learned a lot from this particular session. Thank you so much, Doctor and ASHA workers. So now we're going to move on to the next session. Over to my colleague and Dr. Asabri.
Thank you so much, Resham, for sharing all the brilliant insights, for leading the discussion of panel 2. Now we move on to the third session of today. So good afternoon to one and all. I am Dr. Asabri Sawant, Public Health Specialist at IHW Council, and I welcome you all to the second edition of Preserve the Uterus Conclave on redefining and empowering women's health, an initiative of IHW Council along with Foxy and Bayer. This virtual conclave is part of IHW Council's mission, Preserve the Uterus, and is the third session that we will discuss bleeding awareness across the regions. This panel discussion will highlight the potent synergy between public and private sectors in advancing awareness around heavy menstrual bleeding and hysterectomies across diverse regions. Experts will share successful collaborative models emphasizing on the transformative power of partnerships in women's health advocacy. So join us and explore the dynamic synergies to ensure accurate awareness and information reaches every corner of the society on heavy menstrual bleeding and women's health. So for this panel, I warmly welcome our speakers for the session, Dr. Sharmila V, Additional Professor and Head, Department of Obstetrics and Gynae from AIIMS Mangalgiri. Ma'am would be joining us shortly. I welcome Mr. Sanchit Agrawal, Co-founder and CEO of Numi Care. Sir, thank you for joining us. I also welcome Dr. Reena N.R., who's consultant gynecologist of Government Victoria Women's and Children Hospital. Thank you so much for joining. Dr. Reena, are you able to hear us, ma'am?
Yeah, I'm hearing, ma'am.
Thank you for being there.
Okay.
We will Mr. Chitransh Saxena, social activist and health advocate and founder of My Pad Bank. So thank you so much for joining us. We also welcome Ms. Siji Nair Kaur, who is Head of Marketing for Women's Health of Bayer Zydus Pharma. Ma'am, thank you so much for joining.
Thanks, Dr. Asabri.
With that, let us start with our discussion for the day, which is on the topic of collaborations and empowering voices for raising awareness. My first question is to Dr. Reena. So, ma'am, as we are leading the mission Preserve the Uterus, which is focusing on generating awareness around hysterectomies and the rising burden of hysterectomies all across India. So, can you please highlight, as a prominent figure in the field of obstetrics and gynae, what strategies you have found to be most effective as your role of consultant gynecologist? What strategies have you found effective in educating and empowering patients about heavy menstrual bleeding and the different range of treatments that are available, as many women we have been seeing are not aware of the different options that they can go for treatment of menstrual problems that they are suffering?
Okay, madam. Actually, I am focusing to sensitize patients regarding the effects of heavy menstrual bleeding. Like anemia can produce dull aching pain, malaise and all, and even problems with thinking and breathlessness, etc., etc. I'm actually concentrating to sensitize our women regarding the effects of heavy menstrual bleeding. And now in Kerala, we are conducting this hysterectomy audit and all to reduce hysterectomies, and we are propagating other modes of treatment other than the surgical removal of uterus, and medical management and intrauterine devices. In our state, Hindustan Latex Limited is providing this intrauterine device, the hormone releasing intrauterine device, in a considerably low price. Then the other one, Mirena, it costs around 3,500, but other thing will cost only 2,000, around 2,000, 1,800 and all. And we are promoting this Mirena, that Emily is produced in government sector. Then medical management and proper evaluation of the before that, proper evaluation of the patient. And we concentrate on the small causes like polyps and endometrial hyperplasia, etc. And other conservative treatments like myomectomies and all.
Thank you so much, ma'am. So as you highlighted, that the cost effectiveness is one of the biggest factors that make people want to use a product or, go for something else. So would you feel that, when we compare quality with the cost, there are many times when the better quality product is a little more costlier than the product that is available at a better price. So how do you make the decision as to what to recommend to women, especially when we're talking about cases in which the bleeding is so much that they are considering to go for hysterectomies as the end resort after trying multiple different treatment methods? So is there a guideline that is followed in your practice now, as the government has recently released updated revised guidelines on educating the patients on different options available before recommending hysterectomies? So what is the real scenario in your practice? How many women are open to look into alternative methods before making up their mind?
In most of the cases, is it for me? Question for me, ma'am?
Yes, ma'am. We're talking.
In almost all cases, we discuss all these modalities with the patient, but their symptoms are so severe, most of them resort to hysterectomy. So we are addressing an early intervention, like making them aware of their symptoms. Even a small breathlessness or difficulty in climbing steps like that, we will evaluate that lady for anemia, and mild anemia, we will correct it and find out the cause and treat it. In early stages, most of the patient will come for conservative management. But if patients with severe symptoms, most of them will insist on doing hysterectomy. Still, we will educate them regarding the other conservative managements. And regarding the cost of the product, that LNG IUS, most of the patients at around 3,000 rupees and all, most of them will resort to that LNG IUS.
Thank you so much, ma'am, for sharing all these details. We will come back to you again. But before that, I have a question for Mr. Sanchit, who is the co-founder and CEO of Numi Care. So, sir, you have come up with a brilliant entire landscape around reproductive health and well-being. Can you please highlight a little about the same, about all the different aspects you are covering? Because we have seen there is technology, there is awareness being part of it, also products. So can you please talk a little about that, and also share how innovative approaches and digital solutions is the new it now when it comes for talking about health awareness in particular?
Thank you, and thank you, Dr. Asabri, for having me here, and really appreciate. And it's very encouraging to see the combination of public practitioners and private company like ourselves coming together for women health. So as you rightly said, so we are kind of India's first omni-channel women health platform. What we solve for is what we call as puberty to menopause and reproductive organ cancer. So the day a woman starts her menses, from that day to the menses stop. And the three most common form of cancers: breast, cervical, uterus. So that's the broader gamut of issues we solve for. The way we solve for that is three ways broadly. One is digital, obviously, with the advent of technology, and I'll talk about that. We are able to reach to a wider audience, and in fact, we have customers coming from places, at least, and I joke around in the team that my geography is about India is getting improved, places you've not heard of. So that's the power of digital, so which we are enhancing, harnessing, and I'll talk about that. Second, we have what we have started opening is women only clinics. These are what we call as a phygital solution, where while today you walk into a clinic, your doctor writes your prescription and you take it out, right? And you go and then buy medicine from somewhere, or you get some diagnostic done, or you have to consume hygiene products. We have started building these clinics. Currently, we are in north part of the country, and then we'll broadly go to other parts of the region of India. Is essentially these clinics are essentially there to kind of manage your life cycle. So today, if you are a young girl, you come at the age of 16 and you have certain menstrual issues, and with kind of as you age progresses, there are hormonal changes which starts happening, and currently there is no way we are managing that, right? And majority of the hormonal issues are and we have Dr. Reena and other experts. So majority of the hormonal issues are preventable and curable, right? And if you manage it well, that can be attributed to a lot of other issues women have later in life, right? So what we have done is, interestingly, is you come to this clinic, and then that's where we are using digital, where we onboard you on our platform, and we kind of start tracking. To give you an example, we have introduced India's first period flow tracker, not period tracker. So period tracker, everyone has heard of. Period flow. So heavy, spotty, heavy, medium, spotty, and then you can mark graphically. You can mark. So it's not that you have to measure. You can just mark with a finger on the app or on the platform, and then you can create a trend, a pattern, and you can do it over a period of time and share that with your doctor, right? So that's the second model, where we have these phygital clinics, we call it, where you have the physical presence of a doctor, but after you've shown to a doctor, a lot of the journey is managed digitally. And the third, we're the first company in India to launch women-centric insurance products, where the after COVID, everyone realized the importance of insurance, right? And especially life and health insurance, and a lot of people lost lives. And women, if you see as a category, is the most underpenetrated category all over the world. Forget India, all over the world. And is usually the male member or the head of the family who takes insurance. Whosoever, as it is, the insurance penetration in our country is low. But irrespective of that, it's the male who buys the insurance, not a woman, right? So that's what we are trying to change. It is more relevant in the urban cities, like top 50 cities currently. Obviously, we are working with certain government outfits as well. But essentially, we have launched a women-specific insurance product with some of the large companies like Aditya Birla, ICICI Lombard, and Aviva and all, where we are trying to get as many women under the gamut of insurance and cover their health and wellness needs. So one is the hospitalization part, which is currently available. We are the first company in India to launch a OPD product, out-of-pocket expenses, which are focused on health and wellness, right? The broader health and wellness, be it testing and other things which are not covered in the traditional hospitalization, right? So that's a very quick view of the platform. We are kind of growing very, very fast, as I said, leveraging digital technologies. One thing you mentioned about very quickly, talking about the innovative approach, how we are empowering with more, accurate information about heavy menstrual bleeding and other women health and wellness issues. There are 4 or 5 things we are doing. First, we have a women health helpline. Today, you can go to our platform. It's a 49 rupee consultation you get from a gynac. The reason we have kept it is as low so that there is more access. But we don't want to do it a free helpline, because when we did free, there obviously there is a misuse and abuse in our country. So there is this helpline we are running with collaboration with JPEGO and Wilgrow Foundation, and it is funded by USAID. And the results are amazing, amazing, amazing. Like every day we get 100+ queries, which are focused on menstrual issues, basic sexual awareness, contraception and stuff like that. Currently, we have these helpline in English, Hindi, and Marathi. Interestingly, a lot of the traction we are getting from Uttar Pradesh and Maharashtra currently, and obviously other states as well. Now, gradually, we'll be doing it multilingual, and we'll do around 10 top languages like what you call Bengali and Kannada and Tamil and Malayalam and all of that. So that's one interesting thing, and that's where we are educating and providing the very, very accurate information through a proper gynac. Second, I spoke about the clinics. Every clinic of ours has what we call as a Numi Saheli or a counselor who counsels you. So one is doctor, right? Doctors are busy. Obviously, they write a prescription, but there is a counselor who talks about all these issues. Third, we have a self-help center on our platform. You can go and check it out. So anyone who's registered on our platform can consume a lot of content which is verified by medical professionals and a lot of DIY things which you can imbibe. Fourth thing we are doing is WhatsApp communities. I'm not sure you guys are aware. WhatsApp has introduced a very interesting thing called WhatsApp channels. And that is what we are started leveraging. It's still new, where we are disseminating information through our care buddies to a larger population. That's the fourth thing where we are doing some level of innovation and using technology to disseminate information. The last two things very quickly we are working on is a chatbot, which will be vernacular. Again, 10 languages. It's in progress, but very soon we should be able to do that, because we very quickly realized a lot of time people are very shy to talk about such issues. They don't want to get on a phone, or they don't want to, and in emails don't work in our country. So they are very comfortable chatting or typing, right? So that's where we have started building that. And the last thing, very interesting, we do it with Assam Tea Gardens, is where I'm not sure, I'm sure everyone is aware that Assam Tea Gardens, majority of the people who work in these tea gardens are women, 90% plus. And there are these dispensaries or centers, but they are like age old, not upgraded. And these women don't have access to primary healthcare, and they have to, go to 5-10 kilometers far away to, even get basic access, and especially in case of menstrual bleeding and all of that. So what we are doing very interesting is working with a partner of ours is to establish digital screens in each of these centers, in these tea gardens. So every tea garden has a small setup, a booth kind of a thing, where you have a digital screen, and that digital screen connects to our corporate office here with our doctors, and person can come in and just dial. So you don't have to have a mobile phone or anything. You don't have to be digitally savvy. You just come in, punch a number, you get connected to a doctor here who will give you the right advice then and there, versus you waiting to go and catch a bus to go to the nearest primary center. So I'll pause, but bunch of things, very, very kind of excited to what we are doing as a company, and the collaboration and the effort we're getting from the overall ecosystem. So yeah, so that's a quick overview about us and what we're doing.
Thank you so much, Mr. Sanchit. There are many different initiatives that you are working, and we can see you are targeting the main focus, which is generating awareness, tackling this problem of menstrual health and hygiene in a very multifaceted way, ranging from technology to partnerships. Yes. Yes. So we will come back to you again, because I have many different questions, and I believe our partner Bayer also has a few different questions along the same lines. But before that, let me move on to Mr. Chitransh, who is a social activist, health advocate, and also founder of My Pad Bank. So, sir, can you please, highlight what My Pad Bank has been doing to generate awareness around menstrual health of women in India, and also what have you seen as your work also involves as a health advocate and social activist? What have you experienced is the reality of awareness around menstrual health and hygiene, or is it still a big taboo even in this day and age when we're talking about educated people or rural people? How has your experience been?
Am I audible now?
Yes, you're audible. Yes.
Okay. A very good afternoon to all. So, during my pad bank, starting days of my pad bank, I observed that it's just not a taboo in rural areas; it's a taboo in urban area also. And when we worked in rural area, I observed that educating rural people is easy. Like in comparison with the urban people, like if you are if I'm educating my sister or my colleagues or my friends, then they are not talking openly or before 5 years when I started in 2018. So that was a very big challenge to talk in urban area also. People are not very comfortable with talking on these topics. And when we talked in a rural area, so I saw that people are very open-hearted. They are welcoming us. They just know that someone is if someone came here or came in our society or came in our community to educate ourselves. So he is providing a good knowledge, a good thing to us. So, like for marginal community or for community-based people, so for menstrual bleeding or heavy menstrual bleeding, we worked in rural underserved school education institute for raising awareness on menstrual hygiene, management, and for easy access of menstrual hygiene product. We installed sanitary pad vending machines. We started DIY workshops for making their own cloth pad, for how to use cloth pad, and also even in cities also, even in metro cities also, girls don't know about how many products, menstrual hygiene products are there for means how many options are there in market available for their menstrual for and managing their menstrual bleeding. Like I know only 7 products. I took a survey in schools and in societies also. So usually girls know about menstrual cup, tampons, and cloth pad only, and normal sanitary napkins. But there are multiple products are available in market, and you may you can get from other manufacturers also. We introduced to rural people period panty also. During my work, I observed that some of communities are not allowing to use underpants. Panties are not allowed in their community. So how they're managing their periods during menses? So we provide them period panties also, and period sponge is also a product for managing menstrual hygiene. And also in our session, whenever we took a session in a school or somewhere, so we include a doctor, we include a yoga instructor, we include a dietitian, so that people can ask their question in 360-degree. Like if someone want to know, I'm having menstrual disorder, I'm having this problem, and I don't want to go on environment friendly products. I'm just using the normal plastic pad only, and my comfort is in that. But I just want something yoga poses, or I just want something dietary plan, so that I can feel more comfortable. So yeah, we are doing a session with expertise, and looking forward with after this session with all the dignitaries, so that we can work more widely, or we can work in more fields.
Thank you, Mr. Saxena. We will get back to you on what you shared around the same. So as you emphasize that the awareness aspect, it's not just lacking, but also in urban cities, and educating and informing, as you shared, to urban population is even more difficult. So yes, we have also been working along the same lines under the
Additionally, I just want to discuss one thing more. Hysterectomy, I saw that it's just a method for doctors or other medical practitioners. But during my work, I saw that in UP or in some other areas, the laborers are forced to remove their uterus for doing this hysterectomy, for many. For getting rid from HMB. So like the supervisors of laborers or some families like forcefully doing this method so that they can't so that heavy menstrual bleeding can't affect their work or these things.
Yes, we agree with you. We have some studies lying with us, and we have also interacted with some of the health activists that are working very actively on this regard, such as Dr. Narendra Gupta, who is also part of the latest guidelines that came about around strengthening protocols around prescribing hysterectomies. So yes, that is true in some parts of the country, unfortunately, and awareness is being created now even more in this year to make people aware that there are alternative methods and options for them, for those who are suffering from heavy menstrual bleeding, before resorting to the ultimate option, that is hysterectomy, which should be the last resort. So yes, and we have been working this mission of Preserve the Uterus along with Foxy and Bayer since 2 years now. This is the second phase that we are in, and we are constantly exploring different avenues of collaborations and partnerships with different organizations with the same mission, so that we can come together and generate awareness around this issue, also come about with some better ways to reach out to the masses, not only for generating awareness around menstrual health issues, but also for collaborations around heavy menstrual bleeding aspect and awareness amongst women. So yes, my next question is to Ms. Seji from Bayer. So ma'am, you have been listening to the conversation going on, and our topic for discussion is empowering voices and partnerships and collaborations for better impact. So what are your thoughts as to the role what private pharma companies are playing and potentially can play even in future to create an even bigger impact and collaborate with public and private organizations with similar goals for addressing health challenges like heavy menstrual bleeding? And how has Bayer's collaborations so far with other organizations helped in creating a significant impact in educating and empowering communities around heavy menstrual bleeding, hysterectomy awareness, etc.?
Yeah, thanks, Dr. Asavri. So very well said that public-private partnership is very, very critical. And it's nice to see so many initiatives coming in, with what Numi, Mr. Sanchit shared, Mr. Chitransh shared, and also the perspectives that came from Dr. Reena, as well as even from the previous session, right? That in terms of what are the myths and what are the challenges that are faced by the healthcare professionals and even the patients, the understanding is very different. So this makes it even more important that public-private partnership work together. Okay, and it is crucial that they address the health challenges in women's health, especially when it comes to heavy menstrual bleeding, which is our topic today. And because they bring in the expertise, they bring in the resources and the networks of not just public, but the private sector as well, which can create more synergies, and the required solutions can come out of it. And as you said, this collaboration has been there, but the learnings are there every day, right? Like whenever we are interacting with the healthcare professionals, with other partners, we get new learnings which can then be executed and formed up as a plan to further strengthen the collaboration. Now, these combined efforts which would come from the public-private sectors are important because that ecosystem is required to raise the awareness. To build the capacities amongst healthcare professionals also is critical, because we understand that, hysterectomies are recommended and, where in many cases which can be avoided. So how can the right voice or the right information reach all the stakeholders becomes critical. Now, so having said that, what's important is the quality of information which goes, the right quality of information that goes. And we also saw that these challenges would vary from, place to place. So then addressing them with the help of this partnership is critical. Now, Bayer has a long-standing commitment to advancing women's health through strategic collaborations with various partners. We've been able to leverage our strengths in research, in innovation, and also in healthcare solutions to make a meaningful impact in women's health and specifically in heavy menstrual bleeding. Now, this is through, you've already mentioned this, through the Preserve the Uterus initiative, which, as you mentioned, is in collaboration with the esteemed organization FOXY and IHW. And this initiative has actually reached out to HCPs, healthcare professionals, and women with the aim of increasing awareness and also having targeted interventions by channelizing accurate information, what is required at each of these segments. With this collaborated effort over last 2 years, this initiative has reached out to multiple, as in a significant number of healthcare professionals and even women through meetings, through digital and print media in the last 2 years that the initiative has started. Further, I think what's more important is providing educational materials and access to information through various channels. So that can't be limited. And whatever, is being done probably is still little, with all the challenges that we have and the scale that is required for awareness. So therefore, like-minded organizations coming together and working towards increasing awareness and the right information being given so that the myths are taken care of and women can ultimately lead a better quality of life and don't have to face these issues which can be avoided, which can possibly be avoided.
Thank you so much, CG. So as we are talking about partnerships and collaborations in women's health space, and we have Mr. Sanchit from a health tech background where everything, all the efforts and work is very fast paced from, he's from that sort of mindset. So I will leverage this opportunity and have him answer some questions for our benefit today. So sir, as you've been hearing Ms. CG talk about this Preserve the Uterus mission and me also talk about this initiative. So if we were to collaborate with organizations such as NUMI, how can we both benefit each other? What are the 3 things that you come to mind would benefit you from this partnership, and few things that would help us in better reach our mission, that is awareness around hysterectomies, heavy menstrual bleeding, and women's reproductive health overall.
No, I think fantastic question. So before I answer that, I think one thing I always visualize this picture of a circle, right? Which is that healthcare, when you have to look at healthcare, you have to look at it as an ecosystem, right? And a lot of us already are talking about that, but at the center of it is government, right? Which is making the policy, which is defining the infra to an extent, right? Then the next layer is, or the next lever is your HSPs or healthcare service provider. It can be clinicians, doctors, hospitals, and your diagnostics, screenings, whatnot. Then you have pharma companies like Bayer, which is providing the cure part of it. And then the product companies, like you have IoT devices now, right? Tech devices. Then you have insurance. I strongly believe as a country, we have to go a long, long way to bring insurance into the forefront, unlike some of the developed countries, because the overall expense good quality healthcare comes at a price, right? And then there are companies like us who are trying to be pivotal and be in between and bring bring everyone together, right? Through digital solutions. So I think that's how I personally look at, or we at NUMI look at it, that it is an ecosystem. And then we are very, very focused, obviously, on women health, but there are other players who are doing more horizontal, other specialties like oncology and nephrology and not, right? So I think that is one way we look at the ecosystem. Now, from benefits perspective, so I'll give you some examples, right? So we, for example, working with Willgrow or USAID, where we are very, very heavily focused on driving education across menstruation, across sexual health and family planning and whatnot, right? And that's where we are doing some very, very interesting things, right? We are working with educational institutions. I think Chitransh also spoke about, but where we have something called a campus ambassador, right? Where we nominate, and you be sponsoring that, by the way. We are sponsoring that, and we are educating more and more women young, right, at a very, very early stage, and where we are talking about these issues and then them kind of bringing them to the forefront, saying, hey, these are the things you have to start now, which can help you the overall journey, right? We are working with other brands, menstruation brands, like there are a bunch of, I think we spoke about the pads and then the tampons and the menstrual cup bands. So that's where we are working with a lot of brands like Boon, Sirona and all, where we are collaborating amongst ourselves as on the private side. Now on the government and on the what you call the HSP side is, see, the other we have to see, as I said, once you have done the identification of the problem, somebody like the doctor is kind of curing you, writing you medication, but then how do you ensure that your journey is managed and it's not happening again, or you are taking care of yourself, right? And then that is where I think is very, very important to do an integration. One thing which is we are focusing on or working on is ABHA, right? I'm sure all of you are aware, and we've not spoken about that, right? But ABHA is a very, very powerful tool which will help collect a lot of data and information and then kind of disseminate that through kind of various channels and methods, right? So I think for us, it is very, very important that we work with all these 4 or 5 partners I spoke about, because alone we cannot do anything, right? We are solution providers, but we need clinicians, we need pharma companies to continue doing research, right? We need devices to come. We need government to support through all these initiatives like ABHA and all, right? So from us perspective, it's a no-brainer that we have to work across the value chain, across the ecosystem. And the more collaboration we do, the better I think we are improving the overall access to health, good quality healthcare, and access to information, as you rightly said. And each of these pillars I spoke about have a role to play. That's our personal perspective, right? So yeah, so I think that's a very high level view of ours.
Thank you so much. So before I move to Mr. Chitransh, I wanted to ask one question to Dr. Reena. So ma'am, we had a few ASHA workers, 2 of the ASHA workers be part of our previous session with us, and they were from Rajasthan. They highlighted this thing that white discharge is one of the common reasons for women in lower socioeconomic backgrounds to go and demand for hysterectomy, as they feel it is something abnormal that is hampering their energy levels, their strength, etc. These are the thoughts that they have. And coincidentally, our district health doctors from 2 areas, Davangere and another area in Karnataka, also highlighted the same aspect, that many women that come are having this white discharge as one of the reasons for demanding hysterectomy, saying that they do not want to keep up with the uterus as they already have children, so they do not feel that it is necessary. And hence we can conclude that awareness around the various aspects of preserving the uterus in the body, even after its primary function, which is bearing children, has been served, is not rightly there amongst people, specifically people in lower socioeconomic backgrounds. But I believe the role of uterus after giving birth and its awareness is not even there amongst urban population women as well. So what would be your take on this? How to generate more and more awareness? How can doctors collaborate with ASHA workers, doctors of the district, hospitals and community centers, be more in touch with ASHA and A&M representatives, so that most of these doubts and issues, instead of being transferred to the doctor in the district hospital, gets taken care at ASHA level only? So what would be your suggestions and thoughts around this?
Okay, nice question, ma'am. Actually, I was thinking about talking like this, talking about this thing also, this thing. And it is basically lack of awareness in the community. That is the reason for this type of demand. It is better to create an awareness even among school children. it is a better time to catch up them. And we have to conduct some adolescent health classes or some awareness classes in the schools, so we can introduce the functions of uterus. Or it is not the childbearing is not only the function, but there are so many other hormonal and prevention of non-communicable diseases like that by the female hormones produced by ovaries. We have to enlighten our children regarding this point. And like that, we can conduct classes for ASHA workers and junior public health nurses regarding this importance of retaining ovary, retaining uterus and ovary, even after childbirth, and its significance and its importance in maintaining a woman's health. And making awareness about the initial symptoms of the uterine diseases of.
I believe there is some network issue at Dr. Reena's end. We've lost her.
Regarding the causes of white discharge and causes of bleeding per vagina and other modalities of management for uterine masses, like conservative removal of the swelling alone, and the treatment of a disease is removing that disease. Not actually, surgery is not a preventive measure. We have to make aware the public or make aware our patients that by removing an organ, if we are doing a surgery, and so as you are doing a surgery, you have to be removing all organs inside the abdomen, or thorax is not the way to treat. We are treating the disease only. If uterus, there is a disease in the uterus, we have to remove that disease only, not the uterus.
Got it, ma'am. Understood. Thank you so much. So as we were discussing the various issues with the ASHA workers, one of the very alarming things that I came across was both the ASHA workers were not given any pamphlets or any tech devices to disseminate the information amongst their women, and they were solely giving the prescription, verbal prescription or treatment verbally, not showing any infomercials, no brochures, no pamphlets, nothing. And talking about mobile phones, tablets for showing videos of easy to understand awareness subjects was even more far-fetched. So my next question is to Mr. Chitransh. While we are discussing this aspect as to strengthening our ANMs and ASHA workers and making them more informed to tackle a great deal of women's health issues by themselves, and not having to refer for basic awareness related queries and issues, how can we work together with organizations such as health tech companies who would provide the ASHAs or the government directly with the means and the technology, with mobile monitoring apps, for example, or devices to display accurate information or awareness in videos, etc. How can those sort of things be pulled off, looking at how big our country is, how many people are there, and how remote our remote towns are? So what are your thoughts around that? Sorry, you are on mute. Please unmute. Yes.
Okay, so first of all, I just want to share that there is much more information, like every type of information is available everywhere. Like some of our neighbors or some of junior medical practitioners or on internet, people are reading multiple information on each different platform. So the ASHA workers or ANMs, they need to be trained from a good practitioner or a proper I can say a good doctor, so that they can disseminate, they can provide the better knowledge, or they can at least advise a good thing. We can say in our society or in our in our neighbor or communities, there are multiple people who can advise on anything, and they advise that thing which is not good for our health, in my session, I always introduce to people that everyone having a different body type. Like if I'm having different body type, another one is having different body type. So if a method or if a medicine is good for me, that it doesn't mean that the same medicine is good for other also, or the same diet is good for other also. So for raising a good awareness or providing a good information, yeah. So providing good information or particular information, we are doing sessions with the highly expert doctors and with the healthcare institutions, NGOs who are working on the same topic since last many years, or we can say those who are having good or target on these things. And some of our information materials, like I can say some of our partners like Menstrupedia, maybe you know about Menstrupedia. They are providing a good information through their comic type of illustratives. So mainly there is a need to spread a good or particular information so that people can know about these things. And also some of schools, the schools, those who are helping to conduct these types of workshops, so that we are providing information to only boys schools also regarding menstrual hygiene. So in our session, it means in one of our session, I asked to principal that we are here for providing session on menstrual hygiene awareness. So the mindset of that principal is this is only boys school. There is no use of this means menstrual hygiene awareness is not relevant to that. So I just shared my thought that a boy is also surrounded by some girls. He is having sister, he is having mother. So for a wider range, we started our sessions in boys also, schools also. And some of our partners like I can say Paripads, Menstrupedia, Wonderize, and Sirona, they are helping us for reaching more people. Like we are basically we are working on ground level, but for sharing our work to wider audience, we are using our different platforms. Like we are using WhatsApp channels, we are having WhatsApp communities, and through the doctors and the patients, those who are visiting at OPDs in our district hospital or civil hospital, so they can also join us. They can also call us or ask for anything. Like as we already know that in an OPD, doctors and ANMs are having less time, just because there are multiple patients or multiple gathering are there over there in an OPD. So as a patient advocate or as a health advocate, menstrual hygiene advocate, we work like we are providing a camp over there, so that if a doctor is having less time, so we can provide a better or a good information so that they can take care of their health. Yeah.
Thank you so much. And very rightly pointed out that, awareness around menstrual health and hygiene, not only for women, but for men as well, because they are also part of the community, and having informed men would lead to informed families in future. So definitely very important on that aspect as well. Before moving on to CG, I have one question for Mr. Sanchit. So, sir, I was speaking to one of my friends from a renowned FMCG organization, and they swear by this. When it comes to marketing and promotion, they really value the value of a good ad film in converting people, in motivating them, and also in generating this thought process in larger public's mind around that particular product. So what are your thoughts if health organizations, health promoting organizations also use this method of B2C ad films to target wider national audience? In that sense, would that be effective? Would that be any good? Or if you can highlight your insights on some successful strategies that you've come about while you're working.
No, so I think this is a very interesting question. This is an expensive way to do it. So if people have money, why not? Right? I would say that. But I think if you see fundamentally, when we are talking about such education, let's say I'm a girl and or a woman, and I have to learn about it. You will go to a source which is where you trust or you get inspired, right? Either you trust your doctor, you trust your family members. So I'm a young woman, I will trust my mother or my grandmother or any of the family members, or my doctor, because I know that person is qualified, or someone who's an inspiration to me and I look up to him or her, and if that person is communicating, then yes, maybe I will listen to you. That's a typical human nature, right? So I think we strongly believe, like, obviously the medium can be anything, but the point is it should be from a trusted source. So that's very, very important in our view, that it has to be a source which is trusted. Now, how do you disseminate information? I think there are two ways in my personal view. So one is people who are digitally savvy and have access to digital infrastructure versus underserved or people who do not have access to that digital infrastructure, right? So you have both kind of, and it's important that, and I think I seldom say this, that women is a woman, right? If she's in urban kind of a setup, or she's in a setup where she doesn't have access, at the end of the day, the right information is everyone's right? So now what typically the way we think in our company is two ways. There is a section. So we are a profit with purpose organization, we call it, right? So at the end of the day, we do make money, otherwise we won't survive. There is a digitally savvy audience where the dissemination of information through, I spoke about few things in the beginning, like a helpline or a chat bot or a kind of a very concentrated education material, WhatsApp channels and communities I spoke about, right? So that's one way you are talking about. The second way where we are doing is where it is an underserved population or you have limited digital infrastructure. I'll give you an example of underserved population. We do a lot of work in Chhattisgarh, Maharashtra, and some of the other states, which is as a kind of a CSR initiative for a lot of large corporations. So every corporation has now a ESG and a CS. So earlier used to be a CSR budget, now they have a ESG budget as well, right? So that budget typically a lot of people are recognizing that goes to mother and child kind of education awareness, right? So I'll give you an example. I cannot name it, it's confidential, but working with a very large insurance global company where they gave us objective of educating young adolescent girls about menstrual hygiene and ways into it. So we kind of went very regional. We took Marathi speaking. So it was in Maharashtra. So we took Marathi speaking doctors and educators, went there, and this is very, very phenomenal. I want to share this the idea was to educate young women, right? But we did very regional, and we kept the communication very, very simple, right? Literally in what you call in Hindi layman terms, or thinking the other person doesn't understand anything. The communication was so simple, and the girls got it. And you won't believe, within a week there was a request from that group. So there were 100 girls at one time we educated. There's a group. There was a request to educate their mothers and their family members, because we need this education. We now have impart, and these were young girls, 14, 15. They went to their mothers and, mom, we learned this, and it was in their local language. It was kind of specific to their kind of zone, community, and whatnot. We actually did an additional session on our cost, which was about educating their mother, their aunts, and whatnot, right? So I believe, while these mediums are there, I'm not saying that is right or wrong, right? It's just that it's an expensive way. Ad films are not cheap, right? Let's accept it. Now, somebody like a Bayer sponsoring it, we would love to do it along with them, but just joking. But at the end of the day, what are the cost-effective ways where you are able to impart that impact? And I personally believe in India as a country, it has to be vernacular. It has to be in the local language or the local region or the local dialect you're talking about. Then the impact is humongous. And we've seen this multiple places, right? And it has to be from a source of trust. I think if we are taking care of those two things, the medium can be anything in our view.
Thank you so much for clearing those queries. Thank you so much. My last question for this session, as we are near to the time, is to Ms. Seji. So, ma'am, what are the strategies that you have found effective in ensuring that heavy menstrual bleeding awareness efforts and also reproductive health awareness efforts and culturally sensitive topics such as these are accessible across diverse regions in India? And can you share some insights into any innovative approaches or tools that have been instrumental in reaching the underserved population?
Yeah, thanks, Dr. Asavri. I think some bit of it, Mr. Sanchit already addressed, like in terms of, what could be a cost-effective way of reaching out to more people. Because ultimately we are talking about scale, because it's not a limited population who is affected with these issues. So more the number of people we are able to reach, it becomes more, impactful. So India being a country which is so diverse and with so many languages and even cultural specificities which are there, which makes it, challenging as well, because one myth which is there in one state could be a little different, when it comes to the other state. And language, having information in the right language also becomes critical when we are addressing these populations. So the understanding of the disease, the nuances which vary from state to state, how do we help? How do we also offer, even when we are offering counseling materials, are they addressing these typical issues which even the healthcare professionals have to address, becomes very, very important. So right information, I think Mr. Chitransh also highlighted the same thing, that right information is critical. Trusted source, as Mr. Sanchit mentioned, becomes very, very important. And in a language that is understood, simplistic language that is understood. So simplifying information, one, and also the channels which are employed to make it reach more number of people. These are two things I think that becomes very, very important when we are talking about addressing the awareness issue. So offering educational materials, proper tools for counseling, videos that have the correct, yet these are vital in creating awareness. And the emphasis must be on even accurate translations, because sometimes we see that we have one information or a material that is prepared in one language, and when it comes to translation, the meaning gets changed. So how do we look at that? Because that's also critical, and so that it becomes useful information across India. So for us, it's been the use of digital medium, mostly social media channels right now, and so that, these can dissolve the barriers of reach and guide the broader audience. Okay, it's not that we are able to reach the entire population. It can't happen without support or of government and other partners, but that's critical. And these platforms are currently helping us in facilitating discussion like these, providing support and disseminating educational content. We have some of our social media pages. One is, in collaboration, that's Preserve the Uterus. But we also have Bayer for Health and Bayer for Her that aim to kindle awareness with the right trusted information from the right sources. And also to foster conversations of care, because once the information is available, that would foster that conversations with the healthcare professionals. They go to the right people to seek information, even, go and consult the right doctor and not somebody who is not qualified to help them. So I think these are some of the things that have been helping us. I can understand that there's a lot that needs to be done, and therefore the public-private partnership becomes very, very crucial. Yeah.
Thank you so much. So if anybody does not have anything else to add on, we will wrap up this session for today, this insightful session. Yes. Anyone?
I think just last thing from my perspective, I think it's very encouraging that obviously there's an initiative you guys are running, and I think it's important as a country that we we do more of these and more private partner collaborations and more of these awareness sessions, and I think I agree with Siji that it has to be done at scale. Like for our country, it has to be done at a massive scale. We cannot do in limited to urban population and just do it selectively, right? So I think happy to engage if there are the other thoughts after the call as well. But I think this is I'm very happy to be on this session and learn a lot from you guys. So thank you for that.
Thank you so much. And with that, we wrap up this very interesting session on the topic of empowering voices for impact, public-private partnerships, collaboration in promoting accurate heavy menstrual bleeding awareness across regions, part of second edition of Preserve the Uterus Conclave on redefining empowering women's health, an initiative of Integrated Health and Wellbeing Council, along with Foxy and Bayer. Thank you so much. I would like to thank all our eminent dignitaries for taking out time from the busy schedule and imparting us with wealth of knowledge and information today. Thank you so much. I would also like to thank our viewers for staying with us till the very end. I hope the sessions were just as insightful and awareness imparting to you as it was for us. We learned a lot so much today. Thank you so much. With that, we sign off now. Stay happy, stay healthy. Bye-bye.
Thank you. Cheers. Bye.